Now, a couple people said they prefer me to leave my camera on. I'm just going to give you two heads up. I drink a lot when I'm lecturing and I move a lot. So if I get distracting, stop looking at me and just pay attention to the slides. I prefer to be walking in a classroom and moving around. So this is quite a challenge for me. You'll see my hands going all over the place in different things. And that's why I usually don't put my camera on, but students have asked me to. So you're going to see me with my camera on. And I'm sorry. So I'm saying I'm sorry to begin with. So you could read through the class objectives, and that's part of our 3-column outline that I'm sure none of you have ever printed, but that's how we break down how we lecture on different topics. Gives it in greater detail instead of that class schedule. So those are what we're going to talk about in this class today. And as you know, IGGI is all about the concepts. So we're really trying to transition to what NCLEX is probably going to talk to you about is concepts. So the concepts of perfusion, the concepts of clotting and immunity are what we're going to cover today. So when we say hypertension, and I need you to understand, not one blood pressure. Like if you just took mine right now, it's probably up because I'm on my second pot of coffee because I have to stay up past my bedtime tonight to lecture to you guys. So the caffeine could certainly have made my blood pressure go up. It needs to be repeated. So it needs to be more than one time. So that's why they'll tell the patient to go in and get their blood pressure taken and then go back in a week later and maybe trend it, for X amount of weeks. But what we really desire, and there's a difference between the ages. So that's kind of important because if you go into, and I'm not going to say, please tell me what a patient over 60 pressure should be. That's a knowledge question, you guys. We need to take it a step further. So if I walked into a patient that was 90 and their pressure is 150 over 90, I'm not going to lose sleep. Do you guys see that? But I'm not going to ask you a question that says, please tell me what the patient's blood pressure over 60 should be less than. That's a knowledge question, but you need to know that information to apply it, okay? Under 60 is 140 over 90. And they're really, really pushing even lower than that, okay? So we'll talk about the Joint Commission guidelines in the next slide. And what they're really desirable, like I just went for my Be Well Within, and they took my blood pressure. And now I'm 55, so we anticipate I should be less than 140 over 90, correct? Because I'm less than the 60. Mine was 108 over 68. So I've been blessed with really good family genes with regard to the blood pressure. So I'm definitely in that normal classification. Do you see that? But if I start trending upward and I start getting to be 120s over 80s, they're probably going to have a conversation with me like, hey, Lorraine, you need to drop a couple pounds. You need to watch your salt in your diet. So I can do things in the pre-hypertensive phase to sort of stop any progression. Do you guys see that? So really, when we're taking these blood pressures, when we go to the doctors, it's about screening and saying, whoa, let's pump the brakes here. You're starting to trend upward. What can we do about that? Oh, you need to lose 10 pounds, or you need to stop eating salt in your diet, or whatever. So in that pre-hypertension phase, that's an ideal time, you guys, to teach your patients and teach them things that you can modify. I can't modify my gender. I can't modify my ethnicity. And I certainly can't modify my family history. But I can modify if I'm a smoker. I can modify if I eat McDonald's every day. So we have to really address those things with our patients. And we'll get a little bit later talking about the DASH diet. We get a little bit later in this handout. But I want you to understand that's a really key point in your teaching with your patient is really having that conversation saying, hey, let's stop anything from going any further. Stage 1, 140 to 159 and 90 over 99, you're probably popping on some sort of medication. Okay, so that's, and again, it's not just one blood pressure, you guys. So if you go to the doctor and it's been repeatedly above 140 over 90, I'm probably buying myself some sort of medication. Okay, in stage 2, definitely way more serious, because now we can talk about organ damage that can happen with those high blood pressures. So I always say the way to understand whatever we're teaching, I don't care what topic it is, if you understand what's going on in the disease process, you're absolutely going to understand how you're treating it and what to look for and why you're treating it. So when you think about what's going on during hypertension, you go, well, that makes sense that I'm giving a diuretic, or that makes sense that I'm giving a vasodilator. So there's different mechanisms that regulate our blood pressure. So we're going to talk about those in a little bit, but there's different mechanisms that regulate our blood pressure. I'm out in the parking lot and you decide to stab me for whatever reason, and I bleed out. My body knows that the blood pressure has dropped, and there's all these mechanisms that come into play to help bring my blood pressure up. It's the same way when the blood pressure goes up. The body goes, wait a minute, we need to do something about this to bring it down. Okay, so understanding those mechanisms are really going to get you to where you understand how you're treating that. Systemic arterial blood pressure. Now, these little letters we're going to talk about in 239 next semester. We go into great detail about hemodynamics, so I'm going to give you a little taste of them. Cardiac output. It's the amount of blood that's going out of the heart every minute. About 4 to 8 liters. No one's going to ask you that this semester, but we will ask you that next semester. So when we talk about it, you're going to know it. So about 4 to 8 liters a minute, blood gets popped out of that heart. It's not the ejection fraction. Ejection fraction on the echo is the percentage of blood that gets ejected out. Okay? 2 different things. How we regulate the blood pressure is, what is our cardiac output? And what is our systemic vascular resistance, or the SVR? And that's the amount of resistance in the vessels. Okay, so if one of those is altered, cardiac output's altered, SVR is altered, your blood pressure could go up or down. That making sense to you guys? So if one of those is altered, your blood pressure can go up or it can go down. So we really want it to be in that ideal situation. So we do monitor. There's some fancy little things that we'll show you next semester, how we monitor people's cardiac output and how we monitor their SVR. One of the things that you've done since 110, and I'm going to pose this as a question to you guys. How do you guys measure the SVR? You've done it. You've measured the SVR. How have you done it? Blood pressure. So you know
when you manually take their blood pressure and you're feeling where the pulse stops when you're
it's just manually taking the blood pressure.
Oh, okay.
Measuring where it stops. It's just you're telling me the resistance in the vessels. You're saying, hello, Lorraine, the blood pressure is 120/90 or 110/40. You're telling me that resistance. You don't need any fancy machines to tell me the SVR. Do you guys see that? As we get more complicated and we start going into the ICUs, we'll learn about different kind of mechanisms that we can measure those things. Just hold on that. You are doing the SVRs right now by doing the blood pressures. Okay, so I said there's ways for us to regulate the blood pressure. And that means up or down, you guys. Okay, so don't think that, oh my gosh, we're just talking about the hypertensive patient, because if I'm hypotensive, the body reacts as well. Do you guys understand? It doesn't just go, well, listen, too bad that you're low. I only work when you're high. So it knows. So in the eye of hypertension, when we talk about baroreceptors, they're in your carotid sinus, the aortic arch. They go, wait a minute, this is really high blood pressure, and it will stimulate your vagus nerve. And when we stimulate the vagus nerve, it drops our heart rate and dilates our vessels. I don't have to do anything. My body knows to do that. So it drops my heart rate and dilates the vessels. So that's the beauty of those baroreceptors. Okay. Renin-angiotensin-aldosterone system. All I need, we're going to talk about it in a little bit more detail in a future slide, but when we talk about this is really a potent vasoconstrictor. And I know that you guys have heard of ACE inhibitors. I know it because you've had to look them up. But I know that you've given lisinopril, captopril, those kind of things that end in prils. So when we say it inhibits the ACE, that means it blocks angiotensin 1 converting into angiotensin 2. And there's a slide in the future, so don't panic to write things down now. But the beauty of the ACE inhibitor is it doesn't allow my blood pressure to go up. It causes vasodilatation. So that's why it's a great drug for somebody who's hypertensive. Okay, so we want to block that conversion of angiotensin 1 to angiotensin 2. And because angiotensin 2 is a potent vasoconstrictor, if I keep producing angiotensin 2, my blood pressure is going up, going up, going up. Okay, so we give the ACE inhibitor to block that conversion. We don't allow for angiotensin 2 to even show up to the party. Okay, we don't even allow it to show up. We block that conversion, and now it keeps my blood pressure down. Beautiful class of drugs, and we'll talk about that in a little bit more detail later, but they're a great drug for heart failure. And I'm going to talk about heart failure, I don't know, next week or something, maybe Thursday. So I want you to really think about those ACE inhibitors and why we give it. So now you know that if I'm constantly producing angiotensin 2, my blood pressure is up and I'm constantly hypertensive, I want to block that. I don't want that to happen. I want to block that. That's what an ACE inhibitor does. Okay. Regulation of body fluid volume. So our body has a tendency to hold on to water or get rid of water, correct? So if I'm really dehydrated and I'm sitting at home and I'm not drinking like I normally would drink, I probably not pee as much, correct? Does that make sense to you guys? Because my body is saying, wait a minute, you don't have enough volume. You have absolutely not enough volume. So the body recirculates that volume and decreases the urinary output. That's one way that I can tell somebody's dropped their blood pressure. They're not peeing as much. They're not peeing as much. On the flip side, if my pressure's up and I'm constantly stimulating that, I could be peeing a lot more. You'll hear the hypertensive patients say, I get up at night and pee a lot. Nocturia. I get up at night and pee a lot. So it's trying to help the situation. But I want you to understand, can these mechanisms eventually fail? Yes. Okay. They're great. But let me say I've been hypertensive for 20 years. Do you think they eventually go, I'm done. I'm checked out. I'm retiring. I'm not helping. I'm done. So it's really important to nip this in the bud early on. Okay. And last is vascular autoregulation. And I'll show you a really nice picture of that in the future slides. If I keep going backwards with the slides, it's because I'm on a Mac, and you know, Macs are backwards from my Windows. So just be patient with me. Okay, so here's your baroreceptors. And again, that vagus nerve, it says, holy crap, my blood pressure's up. I'm going to stimulate this vagus nerve, and I'm going to slow that person's heart rate down, and I'm going to vasodilate. So I'm going to allow this patient a chance to sort of recuperate. Okay. But if I continually, and that's what this bottom sentence means, if I continually high pressure, untreated, the receptors get less sensitive and it's a higher level. So my blood pressure might need to be 150 before it triggers those baroreceptors. Do you guys see that? It's less sensitive the longer that you don't control that blood pressure. Love this slide. I'm a renal girl. You all know that. So we're going to talk about this, and we'll actually talk about this in 239 as well. So as I said, I'm out in the parking lot and you stabbed me. I've been watching a lot of murder mystery shows, so I'm sort of stuck on that. And I dropped my blood pressure. Vomiting, terrible diarrhea, whatever reason, I'm losing volume. The kidney says, wait a minute, this isn't working out for me. And it releases renin. When renin gets into the bloodstream, renin meets up and starts dating angiotensinogen, right? And that gets released from the liver. When renin meets up with angiotensinogen, it forms a child, angiotensin 1. Okay. So now angiotensin 1 gets in my blood, and it travels all the way over to my lungs where the angiotensin converting enzyme is. So that's where the magic of converting 1 to 2. Now we have a grandchild, okay? 1 to 2. And now this right here, I want you to put potent vasoconstrictor, potent vasoconstrictor. So I'm out in the parking lot, I'm bleeding, my kidneys release renin, they start dating, angiotensinogen and renin, and they have a child, angiotensin 1. Angiotensin 1 goes away to college, those are the lungs, and she meets her forever husband, and they have a child, angiotensin 2. And angiotensin 2, potent vasoconstrictor, potent vasoconstrictor. So what it does, because the kidney sense the drop in a blood pressure, it clamps down, okay? Clamps down. So if you look at the vessel on the right-hand side, a little bit open and now really clamped down. And that's great because now it's because you haven't taken me to ER after you stabbed me. And I'm compensating for that loss of volume. Do you think this eventually could fail? I hope everybody's shaking their heads yes. It can eventually fail. And then I'm from a point of no return and I probably die because I've bled out. So we need to fix it at that time. Now, on the flip side, somebody with really high blood pressure, it's like taking a bat and beating the kidneys with a bat and beating the crap out of them. And they're bruised and they're damaged. And I might have a problem. And the reason why my blood pressure is up is I produce too much renin. Okay, so we can draw renin levels on a patient to figure out if they're hypertensive because of too much renin. So it could be a hormonal thing of why a patient is hypertensive. So on the flip side, we want to not have our daughter go away to college and find that terrible husband of hers and have this child. We want her to wait to have that child. We don't want her to have angiotensinogen 2. So we want to block that. Okay, we want to block that. So we're going to keep her at home and not let her go away to college. Everybody got that? So that's how ACE inhibitors work. It doesn't allow for angiotensin 1 to convert to angiotensin 2. The other part of this equation is the angiotensin 2 now stimulates that adrenal gland. And with aldosterone, we're going to hold on to salt and water. Now, wasn't I volume depleted up there in the beginning? And wouldn't I want to recirculate that volume? This is what I'm talking about. When somebody drops their blood pressure, this is what happens. They start holding on to the volume, decrease urinary output, and now they become edematous because they're holding on to volume. Okay. Very important to block this. We don't want our daughter to go away to college and meet that nasty husband of hers. We want to block this. We want to block the conversion of 1 to 2 in a hypertensive patient. Body fluid. So if I decide to eat a whole bag of salt and vinegar potato chips, which I absolutely love, and it's a lot of salt, so I'm going to hold on to the water, okay? And what happens is it increases my cardiac output because I have excess volume. So this is a fluid volume excess patient. And my blood pressure goes up, okay? Now, if I have good kidneys, normal functioning kidneys, normal BUN, normal creatinine, normal GFR, if I have all of that, normal BUN, normal creatinine, normal GFR, my kidneys go, hey, I can handle this excess fluid. You're going to pee it out. And that's where the diuresis occurs. Okay. So if you are in volume overload, URI, no kidney disease, normal kidney function, we'll diurese it out. We'll bring that blood pressure down. Okay. It's when we don't have normal kidney function and if we're constantly hypertensive and we don't correct it, it causes damage to the kidney. It says, well, I don't know what to do. I don't know if I should get rid of fluid. I don't know what I should do. So hypertension damages the kidneys. And then I'm going to hold on to more fluid, more salt. Okay. So your brain, after having this conversation right now, should be saying, I'm probably going to need to watch my patient's fluid volume status. I'm probably going to need to pay attention to what my patient's sodium intake is. Right. And I'm probably going to really have to have a conversation with them about, you better be monitoring your blood pressure at home. So a lot of education is going to be coming up in the future slides. All right, vascular autoregulation. We want to keep perfusion to the tissues constant. And I know that you guys have done blood pressures, systolic over diastolic. Great. And I just told you mine was 108/68. But the more important number, and we'll talk about this in more detail next semester too, is called the mean arterial pressure. And it's an average, and don't obsess about it, but the more important part of that blood pressure is this mean arterial pressure. And that tells me how well the body is being perfused. Because I know you thought when I said my blood pressure is 108, ooh, that's kind of low for her. It's not. That's my normal blood pressure. My mean arterial pressure is perfectly fine. I'm perfusing my kidneys. I'm making urine. So when we're talking about perfusion, especially to the tissues, now we're going to get into what is the patient's mean arterial pressure. And I'll teach you next semester on how to calculate that as well. It's not hard. But this is what I want you to understand. When we have continuous elevation in blood pressure, and it's a silent disease because most patients are asymptomatic, it causes all of this damage within the vessels. And we don't know it sometimes until it's too late. Like I had a stroke, or I have kidney failure, or I have a heart attack. So you can see that the vessel becomes swollen. It becomes hyperplasia, so it becomes larger. If you look at it, it looks just edematous, and you can see how much harder it is for that blood to get through that hypertensive vessel over there. It narrows. So the more narrow it is, the higher the pressure is going to go, right? If I blow through a coffee stirrer, very hard to get that through because it's a small diameter. Versus a toilet paper roll, I'm blowing through that. I can have a lot of air go through that. It's the same concept. You want your blood, your vessels to be like a straw. If it's a coffee stirrer, their blood pressure is up. It's too much resistance. Not enough blood can get through. It's a lot of resistance. If it's a toilet paper roll, there's no resistance and my blood pressure is in the toilet. Okay. So the body can regulate on its own until we've been doing this for 20 years of not being under control. And now we have some end organ damage. That's where we hope we can prevent the patient from getting. So I said, can cause coronary disease, and I'm going to talk about that. A heart attack, stroke, chronic renal failure, diabetes, and hypertension are the two number one, or they're co-number one, I guess you can say, reasons why patients have kidney failure. Diabetes, hypertension, two number one co-reasons why people have kidney failure. You get a peripheral vascular disease and retinopathy. And here's the thing. Patient doesn't even know. They go to the eye doctor and you're like, something's going on with your retinas. And it could be the hypertension. Do you guys see that? So it could cause blindness in patient as well. Again, we need to educate our patient before we get to this point. All I'm going to say about this slide, please do not obsess about this slide. So put next is, I will not ask you a test question on this. I just wanted you to see how this can all play out, the pathophysiology, but please do not obsess about this particular slide. Okay. Nursing questions aren't based on patho, or they shouldn't be. Should be based on what's the nurse going to do for this patient who has terrible pathophysiology. Okay. Concepts that I do want you to understand is a preload is the amount of volume that's brought back to the heart. I don't know if you remember that from anatomy and physiology, but preload, because that's going to be a concept I'm going to teach next semester in critical care. Preload is the amount of volume. So when I have a high preload, I'm volume excess. When I have a low preload, I'm volume deficient. Okay. So we really want to know what our patient's volume status is in the hypertensive patient, don't we? Because we can give them a diuretic if they're fluid volume excess. If they're not fluid volume excess, perhaps a diuretic isn't the right choice. Do you guys see that? So understanding the patient's fluid volume status, that's what preload is. Contractility is just how well that heart contracts. Okay. But please, please, please do not obsess about this slide. I just liked it because it shows how significant hypertension is and how many different mechanisms can occur with hypertension. All right, classifications. 90% of the cases, we don't know why. We don't know why. That's called essential hypertension. Okay, essential hypertension. This results in damage to vital organs. And just like I said to you about, kidney failure, stroke, that's what that's talking about there. That's what that's talking about there. And the problem with this, I have a little picture down below, is it's a silent killer. People are at home, they're hypertensive, they don't even know. I had my mother-in-law here last year and she was all worked up and I sat her down, her pressure was 200 over 120. And I said, whoa, 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 sit down for a minute here. She didn't even know. She goes, I have a headache. I'm like, sit down. So it's really important that we teach our patients to take the blood pressure. So I bought her an automatic cuff because she's 86 years old. She can't navigate a regular cuff. Now, secondary hypertension, and I'll talk about in a future slide, the different causes from underlying diseases and drugs. So, and I'll talk about a colleague that I worked with who had secondary hypertension because of, well, I'll get to it in a minute. I'll keep you in suspense. Malignant hypertension this is where, boom, my pressure goes way up. Okay. And they usually end up in the ICU, you guys. So if you have somebody that has a systolic blood pressure that's greater than 200, please don't go to break and leave that patient because they could stroke. They could have MI, they could stroke. So this is a patient that's going to get transferred to the ICU. Headaches, yes. Sometimes they'll get nauseated as well. They'll wake up with morning headaches. You have to treat this immediately. And I'll talk about those medications that we would use. We would use IV medications. We wouldn't walk in with a little pill and go, here you go, here's your morning blood pressure pill. No, these are very, very sick, very serious patients. They will end up in the ICU and we will have them on continuous IV medication to bring that blood pressure down. All right, so back to my little friend. So let's just talk on the left side. And this is what I talked about. The first three I can't change. I can't change my family history. I can't change my race. And I can't change my age. I can lie about my age, but I can't change my age. So those are the things that I can't control. However, everything below I 100% can modify. And we don't ever, let me say this very, very clear. We don't ever say to our patient, please cut back on smoking. We say, stop smoking. Do we commend the patient that was smoking 4 packs a day and they're down to 1? Yes, but never as a nurse do you say, oh, just cut back. Same thing with an alcoholic. We don't just go, just have 1 drink a day, okay? So you want them to stop smoking, okay? You want them to lose weight if they can. Now, this is going to be a hard one for me. So if you take care of me and I have a high blood pressure in a couple of years, I'm not giving up caffeine. You might as well just call the coroner. I don't know. That's going to be a challenge to give up the caffeine. Sodium I can do without. We can restrict sodium and we'll talk about ways to do that. They can increase their activity. And then let's take a deeper look at what they're eating. Are they low in potassium and calcium and magnesium? So perhaps maybe they're just eating French fries and, well, French fries would have potassium in it, but greasy food and no fruits and things like that. So really having a dietitian come and talk to them. So all of those on the bottom, smoking down, are modifiable. You need to understand the difference between that, non-modifiable and modifiable. Secondary kidney disease. Now, my friend, I think he was in his 30s. And he went to his doctor and his blood pressure was up. So they put him on blood pressure med. Normal weight, was a football player in college, pretty active. But maybe it was his family history. So this went on for 7 years. He was on 7 blood pressure medications at one time. We could not get his blood pressure down. So they finally decided to do a CAT scan of his abdomen. And they took a look at his adrenals. And Debbie, I think, talked about this, right? Pheochromocytoma. And I've had one lady in the ICU and her pressure was 300 over like 180, who ended up getting statted to surgery, but she had a pheochromocytoma. And you know what? He went to surgery, got that tumor removed, and he's on no blood pressure meds now. So really, really being that advocate for the patient and say, have they looked at your abdomen? Have they done an x-ray? Do we see anything going on there? Primary aldosteronism, we can get aldosterone levels. So if a patient's producing too much aldosterone, okay, so we can get an aldosterone level. Cushing's disease, I know Deb just talked about this, where they have water retention, weight gain, okay, and some of the medications, and steroids are a huge culprit. Steroids are a huge culprit. Steroids are great, but they have so many side effects. Steroids will help, not help, but steroids will help, I guess, help your body retain water, and you will be in fluid volume excess and you'll have weight gain. Steroids are a big culprit. Okay, so you really want to educate your patient on that as well. Sympathomimetics will increase your heart rate and increase the vasoconstriction. So really looking at what medications am I taking? Do I have any of these other little brain tumors can produce different hormones to make things go crazy. So pregnancy could be fluid volume excess. Really looking at what's going on with the patient and getting a good history. All right. So noticing. So what are we assessing? One of the things is you definitely have to have that conversation with the patient and look at their risk factor. Do you smoke? We ask these questions on everybody that gets admitted. Are you drinking? What is your BMI? Have you lost any weight? Gained any weight? What is your daily dietary intake? Oh, I eat McDonald's French fries every day. Okay, we have to have a conversation. So really looking at those risk factors that I just talked about that we can modify and having that conversation. And that's why I'm like really nitpicky on your teaching section, because you guys write, I'll teach them about their diet. And I'm like, okay, what are you going to say? Well, just that they should eat a good diet. I don't know what a good diet means. My mother thinks that's chocolate and potato chips. You know what I mean? She thinks that's a good diet. You know, she's 81, what the hell, let her eat whatever. Point being, you got to be very, very specific. So I'll show you one of the ways that we can, in a future slide, about what type of diet to teach these patients about. On their physical exam, probably no symptoms. They may say, you know what, I wake up every day with a headache. But a lot of us do, don't we? We're like, oh, it's because I need my caffeine, or, oh, my eyes, I didn't put my contacts in. Spontaneous nosebleed, I do worry about, because that's excess pressure. And if you have fragile vessels in your nose, you're going to bleed. Dizziness, I'd say probably most commonly patients will say headache in the morning, maybe some blurred vision. When we are seeing organ damage, kidney, heart, brain, we've been hypertensive for a while. Not one episode of you being nervous about a test coming up that your blood pressure goes up is going to cause end organ damage. Okay. So what do we do? Well, one of the things is we want to send a urinalysis. So simple pee in the cup, send it downstairs. It's not a culture, just a urinalysis. And we're looking for microalbumin. So what that means is albumin is a protein. I don't know if you guys know that, but albumin is a protein. And our kidneys should not pass protein in the urine. Protein is a large molecule. So if I am passing albumin in my urine, that means that my kidneys have some sort of damage. So one of the things my doctor does every year when I go, she does a UA and she checks for microalbumin and she looks for it, and hematuria, and the blood could be occult. You may not even notice it. So those two things, and red blood cells are large molecules too. They should not pass. They should not pass in your urine. So protein or albumin and blood should not pass in your urine. If it does, now we're thinking of some kind of kidney damage. Catecholamines has to do with that sympathetic nervous system. So if I'm producing too much epinephrine and causing massive vasoconstriction, that could be a reason why my blood pressure is up. So I can send a urine for catecholamines. You're going to send blood work. We're going to look at electrolytes, particularly your sodium. If you are in fluid volume excess, your sodium could be diluted out and low. If my kidneys are not functioning, your potassium could be high. Creatinine might be elevated because I have some kidney damage. Your GFR, or your glomerular filtration rate, that's how much your kidneys are filtering in a minute, is decreased. Now, I know you've read it on your charts and you see greater than 60. And all the greater than 60 means is at least 50% of my kidney is functioning. So if you see a GFR that is less than 60, we've already had about 50% damage to my kidney. Okay. And we shouldn't spill glucose in our urine. One, if we do, our blood sugar is probably about 200. And two, if our glucose is high in our blood, we really need to look at, is this patient's diabetes not under control or untreated, I guess, if you want to say. Another test that we could do is a hemoglobin A1C. You remember that from Sarah's lecture? Patient says, and my dad's very classic for this. My blood sugar is under control. I said, is it, Dad? He goes, yeah. And I'm like, what's your hemoglobin A1C? Oh, it's 10. No, it's not. No, it's not. So that tells us the control of the diabetic over 3 months. That hemoglobin A1C gives us a great picture of what's been going on with that diabetic patient. I had a patient this past weekend that I saw that was in because of kidney failure, because of his diabetes. And we had to have a chat about changing his diet, increasing his exercise, and getting his blood sugar under control, or he was going to end up on dialysis. So it's really important that you have that conversation with the patient about getting that blood sugar under control. If we do an EKG, you're going to see left atrial and ventricle hypertrophy. So when your blood pressure is up, that means your SVR is up, right? Because I said that's what your SVR is, your systemic vascular resistance. Imagine trying to go through a door that is locked, and you're shoving and you're shoving and you're trying, you can't get out that door. The left ventricle, it's trying to get the blood out of the heart, and it has so much resistance. It's like lifting weights for your left ventricle. It's going to build that muscle up. Now, that's not a good thing for your left ventricle. Okay. The ventricle hypertrophies because it's had to work so hard. And I'm sure you've seen that on maybe a 2D echo or an x-ray. They might say cardiomegaly. You've probably seen that. Really look, because then you say, oh my gosh, how long has your blood pressure been out of control? Because now we have cardiac changes. Okay. Now we have cardiac changes. So there's your complications. Again,
Sorry.
Go ahead.
Can you repeat what you said about the urine's positive for the catecholamines?
Okay, so when we're thinking of sympathetic nervous system release, and we're thinking of like releasing epinephrine and norepinephrine, they cause vasoconstriction. So a way to tell that I'm producing too much catecholamines, I'm going to do a urine. That help?
Yeah.
They'll send a urine and it'll be positive because I'm producing too much of those catecholamines.
Okay. All right. Thank you.
Into my urine. Yep.
Okay.
All right, now which way? Oh, there we go. Okay, so we talked about all of those complications kind of earlier, so this is repetitive, but I need you to understand hypertension is not something to mess with. Silently for years, that's why patients should pay attention to what their blood pressures are doing, because I can have all of these things happen. I can have a stroke, and that's exactly what happened to my aunt, whose blood pressure was not under control, and she had a massive stroke. and she's left side paralysis now from it, all due to her blood pressure. My mother, who's been 100 pounds soaking wet all of her life, is hypertensive. My dad's side's not, so I must have got his genes, but she was never overweight, but she's hypertensive. And I said, you've got to take care of this, because if we don't get this under control, all of these other things are going to play into her future. You know, my mom's 81. So we already do have some hypertrophy of her left ventricle because she's been hypertensive for so long. I saw that on her echo. So it's really important that we really get this blood pressure under control. Okay. All right. That should be DUE, due to, and not two twos. I have a typo there. So, and as I've talked for the first, I don't know how long we've been talking, almost an hour, I spent a lot of time on teaching. You already know what to teach them, don't you? I mean, I just spent a ton of time talking about their diet, talking about exercise, very simple little changes that we can make. You know, and sometimes the physicians will threaten and say, if you don't get this under control, next time you come, you're getting on a med. Okay. So really having that conversation and teaching them about diet, exercise, stop smoking, weight loss, those kind of things. So health teaching and lifestyle changes. So let's go to I'm not a concept map person, but I think you got, this is from your book. And I tried to copy it and I don't know why it came out black, but I like this because it really sets up the scenario. If you look at the guy, he has a history of hypertension and diabetes. You guys see that on the left? Very common. And he's on a April. Look at that. And I said, what is April? What class?
ACE inhibitor.
ACE inhibitor.
ACE inhibitor.
Yes, that's right. So he's already on an ACE inhibitor and he's on metformin, his oral hypoglycemic, okay? Plus he's on some things for his cholesterol. And that thiazide down there, do you see that HCTZ? That's one of the first drugs that we give for hypertension, and we'll get to that in the slide, so don't write that down in a panic. We start with diuretics sometimes when somebody's newly diagnosed with hypertension. So if you look at the expected outcomes, it's not just, oh, I want his lab work to be okay. There are specific parameters. So you want that cholesterol less than 200. You want that LDL less than 100. You want that HDL higher than, 40. Higher the better, HDL. And we'll talk about that when we get to coronary artery disease. Triglycerides, get those down. All of those, hemoglobin A1C. Do you see? We need to pay attention to the lab work to see if that patient's under control. Okay. So it's not just memorizing these lab work. It's having that conversation with the patient going, wait a minute, your cholesterol is 400. We got to do something about that. Okay. So physical assessment, you always, and really on admission into the hospital, you really should take the blood pressure in both arms. My mother has a significant difference between her left and her right. So you really want to know that. So you want to have both arms. So you can tell somebody, oh my gosh, it's much lower in the left or much higher in the right, or whatever you want to do. You want to do the 6 Ps. You want to look at, do they have pain? What is their pulse? What is the capillary reflow? All of those things that you learned in 110 assessment. We're going to talk about DASH, dietary guidelines. Okay. And that stands for dietary approach to stop hypertension, hence the DASH. So we'll talk about that. We're going to talk about monitoring that lab work, really looking at, this is more so when we get into coronary artery disease, really looking at that lipid panel, really looking at the HDLs, the LDLs, the triglycerides. We have got to get that under control. We have got to get that under control. Okay. See, monitor lipid levels. Patients with diabetes have increased lipids, severe atherosclerosis. So the next lecture, I'll be talking about that. Okay. And then you're not allowed to say antihypertensives, but it is here. We're going to administer whatever medication is ordered for them, whatever class it is. And then maybe some meds for the lipids. I'm not going to talk about the lipid meds tonight. I will talk about them when we talk about coronary artery disease. So you will get that. All right. Couple things. I want you to think about this sodium restriction, and it's really kind of high. So I want you to put next to that 2,400, it could be as low as 1,000 milligrams. It depends on the patient. If I'm hypertensive and have heart failure, both, they're going to back off on my sodium. Do you guys get that? So the book says 2,400, but I'm going to tell you, you're going to see it lower in a lot of patients. Get the BMI less than 25, reduce alcohol intake. So maybe, a glass of wine. I think that's a lot of beer, but I don't drink. So, okay, 24 ounces of beer and 3 ounces of liquor per day. Exercise 30 to 45 minutes most days of the week. Decrease stress levels. If you guys have a magic way to do that, let me know. Really, I don't know. I burn, I do a diffuser. I play all kinds of music. Hence why I play that before class. Figuring out a way how to deal with that stress. Avoid smoking and tobacco. That doesn't say cut back. It says avoid. Okay. And then complementary alternative therapy. If a patient chooses to do that, herbals, whatever, they need to communicate that with their provider, because some of those herbals or complementary or alternative therapies could be contraindicated. Okay, so it's really important to ask that question. Patients don't think to answer that when they come in. You're like, what meds do you take? Ask them if they're on any kind of herbal supplements or any kind of alternative therapy. You need to know, because it could potentially be life-threatening. Okay, the DASH diet. And I said that's the dietary approach to stopping hypertension. So DASH, the dietary approach to stopping hypertension. So as you look at the fabulous plate, you can see that, increasing grains and fruits and vegetables, really watching that fat, lean protein, and really educating the patient about sodium intake. Okay. So canned foods, pickled things are all bad options. So when you say you need to watch your salt, patients don't understand that. When I was in college, I loved frozen dinners. They're easy. You throw them in the microwave, dinner's ready, very high in sodium. So really having that conversation of what that looks like. Okay. Canned soups, terrible choice. So really getting them to read labels. Okay. All right. Now we're going to spend some time, and then we're going to take a little bit of a break at 6:30. We're going to start talking about, and this is where the mainstay of my lecture is medications. And I know you guys have given these medications. I know it. So it's individualized. There's no best answer for every patient. So sometimes it's by trial and error. And one of the patients I saw this weekend, she was on an ARB, ARB, angiotensin receptor blocker, not an ACE, but an ARB. And she said, I didn't like it. I didn't like the way it made me feel. I didn't like it. So she went back to an ACE, which most people complain with ACEs because it makes them cough. She said, I don't care about the cough. I didn't feel good on the ARB. So you see, you just don't know until somebody takes the medication what the best choice is. So a lot of times it's sort of, and I don't want to say a guessing game, but it's sort of trial and error, I guess. We start on this medication, and then we go back to the doctor and we say, well, let's see, how's that blood pressure? We've been trending it for a month and it's still not under control. They may add another medication. Most people need 2. And one of the doctors that I work with says that you really want to maximize the first drug. So get them on the highest dose of that first drug, whatever you start on, and then add. So you want to get to that highest level. No one's going to ask you that test question, but that's how you get to the second drug, is you sort of maximize that first drug. You've got the highest dose on that first drug. Now we need to add more. Once a day per therapy is best for compliance. That's why like ACE inhibitors are great drugs, because it's kind of got 2 pills mixed in one, and I'll explain to that when we get to the ACE inhibitor, but it does 2 things, the ACE inhibitor. So it decreases preload, and it decreases afterload. So it's one pill instead of having to take 2 pills to do that. So there's a better compliance because now I got one pill that does the job of 2 pills. Make sense? So again, not everybody is on the same drug. That's why we need to know how each drug is, okay, and what happens with each drug. There are lots of combination agents, and they'll have 2 pills mixed in together. And it definitely helps with compliance. So I don't have to take 2 separate pills. It's 1 pill. So depending on the patient is again. All right. So this is from Lilly, and Iggy has, I think, a chart on this page 725, but there are 7 main categories of drugs to treat. And they usually start with diuretics first. Now, in my mother's case, we didn't put her on a diuretic. We put her on a calcium channel blocker first. So don't get stuck on that. Most cases, diuretic first, and then they start trying these other things. But my mother, they started her on a calcium channel blocker first. And that was 20 years ago. So we're going to talk about each of these classes of drugs and some very unique things that you need to know about these drugs. Certainly, I don't expect you to know every single side effect. But when you go in to talk to somebody about an ACE, you got to tell them about the cough. It drives them nuts. It's a dry, hacky, naggy cough. That some patients will stop taking that ACE because they can't stand the cough. So you got to know these sort of things that go along with each specific pharmacologic class. In the elderly, make sure that you're really monitoring, because they will have, and I don't know if you've ever taken care of a patient that said, I got out of bed really fast and cracked my head on the end table in my bedroom. I mean, I can't tell you how many patients that I've taken care of because they got up so fast and they had postural hypotension. How do I assess for somebody who has postural hypotension?
Orthostatic.
Orthostatic.
You got it. So wouldn't a smart nurse who's starting a new medication on this patient, brand new antihypertensive classification, whatever, it's a diuretic or whatever, wouldn't the smart nurse get a set of orthostatics and see what happens? And I had a guy this weekend too, when I was on call, young guy. And when I mean young, in his 50s, I know you guys don't think that's young, but he was at dialysis and got up really quick and boom, went back and passed out. And I said, oh, we got to check your orthos because he's on a bunch of hypertensive medication and he dropped his pressure. So it's really a smart nursing student or a smart nurse who does her own orthos just to be sure that this patient's safe to get up out of bed because they're going to crack their head. And then you got to send them down for a CAT scan and a neurosurgery consult and the whole deal. Venous compression stockings, i.e. TEDs or SEDs, can help with bringing back volume to the heart if they have issues with a decreased preload. If the patient has issues with a decreased preload, which will cause their blood pressure to drop, the compression stockings help with venous return. Compression stockings help, you remember that from 110, help with venous return. Dizziness, if patient says, oh my God, I'm really dizzy, immediately put them back in the bed, get a set of orthos on them and really evaluate if they're not dropping the pressure getting up. Caffeine and nicotine can affect the blood pressure, make orthostatic changes greater. Your patient may be on a caffeine restriction. They might be on a nicotine patch, hopefully getting them off of smoking. So you really want to know those things as well. All right, let's take a break till, let's take a 5-minute break, 6-minute break till 6:35. Let me pause the recording. Okay, so what we're going to do is we're going to go over majority of these classes. So so when you are talking to your clinical instructors now, they're going to want to hear you say, I have a beta blocker to give, or I have a calcium channel blocker to give. So if you look to the left, under cardiac factors. So if we have somebody who's tachycardic, a beta blocker would be a great choice because beta blocker not only vasodilates, it slows the heart rate down. So does a calcium channel blocker. The centrally acting adrenergics, I don't give as much. Beta blockers are probably, you've heard of metoprolol, like tenormin or atenolol. And then the calcium channel blockers, Norvasc, Cardizem. So if you have an issue with fast heart rate, you might see them on a beta blocker or a calcium channel blocker. If I have an issue that has excess volume, because I'm a heart failure patient, in addition to a hypertensive patient, we're going to give a diuretic or an ACE inhibitor or both. And then you can see down here, if I have issues with hormonal issues like too much renin, something along those lines, you might see an ACE inhibitor or angiotensin blockers. So we'll get into these, each classification a little bit more in detail as we go along. So remember what I said, that diuretics are the first choice. And more often than not, the thiazide diuretics down there on the bottom are your drug of choice at first, okay? So depending on where you, or which diuretic they choose is where it works in the kidney. Loop diuretics work in the loop of Henle. So that's why they're called loop diuretics. So it really just depends on what type of diuretic we're on. So let's just talk about this. First line for hypertension, decreases excess volume. So preload, remember preload is associated with volume. So if I have too much preload, I have too much volume. So your therapeutic results, what do you want to happen? That volume to go down. And if I have too much volume, I have too much cardiac output, we want that volume to go down as well. So that cardiac output will drop down too. Decreased total peripheral resistance, or that SVR. So you want those vessels to be dilated, not so constricted. So we want them to sort of relax a little bit, not be so constricted. The overall effect is to decrease the workload of the heart and decrease the blood pressure, okay? And like I said, thiazide diuretics are used, are the most used diuretic for hypertension. Loops, I'm sure that you have given this. Loop diuretics, they work in the loop of Henle there. It will excrete potassium, so you are always chasing the potassium in these patients. Somebody on a loop, you should anticipate looking for a potassium level. And any diuretic, you guys, you should be looking at the BUN, creatinine, and GFR. Any diuretic, okay? Because can I give too much diuretic and make them too dry and then make them volume depleted? Yes, drugs are great, but I can overcompensate and give them too much. And then now I've dropped their blood pressure and I've made things worse. So again, it's that fine line that you have to walk, that is their blood pressure okay and is their blood work okay? So Bumex, we can run as a continuous drip. We can give it IV. We can give it oral, or we can give it IM. And I think I've only given Bumex IM once because I didn't have a line. Okay, so most often than not, we're going to give it IV if it's an emergent situation. But if I'm going home, I'm going to go on oral tablet. This Edecrine, rarely used. At least the doctors that I've worked with, I've not seen them order that ever. It can cause ototoxicity, so toxic to your ears. Now, too much of a loop diuretic can also damage your hearing, so you want to educate your patient if they start noticing any ringing in their ears or if they have a decreased ability to hear someone. Pay attention to that. That is a side effect to the loop diuretics. Now, Lasix, I can give a Lasix strip, continuous. I can give it IV push. I can give it oral. And I mean, I've been giving Lasix since 1990 when I graduated, and I never knew this until somebody told me this before. Lasix, the word 6 in it, works for 6 hours. So if I take it at 8 a.m. for 6 hours, I'm going to be diuresing. So Lasix, no one's ever going to test you on that. I just thought that was kind of a fun to know thing. But you can give Lasix as a continuous drip. Demodex could be IV push or tablets. Okay. Most often you're going to see in a drip is this Bumex. This is what we've been using at least at Bon Secours right now. I do see a lot of oral Lasix patients on that at home. Haven't seen as much Demodex, and I don't know if the drug rep just hasn't been around or what the reason, but the Lasix and the Bumex are the two most common ones. So it has renal, cardiovascular, metabolic effects, so act directly on the ascending limb of the loop of Henle. So it inhibits chloride and sodium reabsorption. So that means if I don't hold on to sodium, I don't hold on to water, do I? So I'm gonna get rid of. So renal prostaglandins causes vasodilatation and it decreases the resistance in the peripheral vascular, okay? Now, great drug for somebody who's got significant edema. Chest x-ray shows pulmonary edema or heart failure. 3+ pitting edema. They're up 20 pounds. Great drug, and probably going to be IV. Okay, so definitely, if a patient has edema, you're going to see them pop them on some loop diuretics. Potent diuresis, and you're going to lose the volume. So remember, you need to pay close attention to what your patient's volume status is, because you can overcompensate. And now your patient has a blood pressure of 70/40. Don't make that phone call. Assess before giving these meds. If your pressure is already low and now you're going to give a diuretic, you're going to make the pressure even lower. Okay. So it decreases the fluid volume, decreases the blood pressure. This pulmonary vascular resistance comes into play if people like that have pulmonary hypertension. You got a lot of pressure in that pulmonary artery. Systemic vascular resistance, that's that resistance that the heart has to work against to get the blood out of the heart. Central venous pressure has to do with preload. So that has to do with the amount of volume that's in the patient. So if a patient is in edema, pulmonary edema, excess volume, their central venous pressure is going to be high. We want it to come down. That's a therapeutic effect. We want it to decrease. Left ventricular end diastolic pressure. So that's at the end of diastole. What pressure do we have in there? If a ventricle is really, really stretched because of excess volume, that pressure is going to be up. Anybody know what blood value I look for when the ventricle has been in overload and stretched? What blood value tells me that I'm in heart failure?
Is it BNP?
You got BNP. Clearly, you get that patient comes up and their BNP. I just got one on a patient this weekend. Hers was 5,000. She has no history of heart failure. Her blood pressure was up. She came in and she was in renal failure and her BNP was 5,000. Never had a problem with it before. Only because I heard crackles on her lungs did I think to get a BNP. So pay attention to your physical exam on the patient. She had absolutely no edema in her ankles. The only thing I picked up were crackles in her lungs. Only thing. So it's really important that you pay attention to, and I said to her, you have crackles. She's a nurse. And I said, you have crackles. She goes, what the hell? And I said, so I drew a BNP and she's in heart failure. Wasn't short of breath, wasn't hypoxic, in heart failure. All right, so we can lose potassium and sodium. Potassium more so than the sodium. So your brain says, if I'm on a loop, I better be watching my patient's potassium level. And that's one of the first things that I treat first thing in the morning when I go on rounds is I look at people's potassium levels because they've been on a Bumex strip or Lasix or whatever. You need to closely monitor that potassium level because it will drop critically low. All right, so what adverse effects? I mean, the dizziness, definitely because of decreased volume. The tinnitus or tinnitus, whatever you want to call it, is because it's ototoxic. So the patient says, oh my God, my ears are starting to ring. Your brain should say, whoa, maybe I'm giving her too much diuretic. Notify the healthcare provider that she's starting to complain of ringing in her ears. Every drug, I don't care what drug it is, you guys, causes nausea, vomiting, and diarrhea. I don't really care about that. Every drug causes it. So with agranulocytosis, so if we're looking at something like that, we're really looking to see what kind of severely low white blood cell count. A severely low white blood cell count, dangerous. So we're looking for that absolute neutrophil count, and that's where that neutropenia is there, which puts us at risk for infection. Puts us at risk for infection. So if you're getting a CBC on your patient, you're really monitoring those neutrophils, because that's telling me that something's going on here. Because the neutrophils are the guys that run and sort of start to fight off infection. So it's really important that you pay attention to their CBC as well. I already talked about hypokalemia. You have got to monitor their potassium levels. Blood sugars can go up with this diuretics, and also your urea levels can go up as well. So your uric acid, not urea, uric acid levels. Your uric acid levels can go up. Anybody know what metabolic state I'll be in? Will I be alkalotic or acidotic with these drugs? Got a 50-50 chance.
Alkalotic.
Why am I alkalotic?
Low potassium.
Yes,
Is
partially.
it has to do with the compensation?
Nope. So your potassium drops, and you guys probably remember that from 112, that a low potassium goes with metabolic alkalosis. That's great. But when we give these diuretics, and I don't know if it's on the next slide or not, it makes your venous CO2 go up. So you know how you guys get a potassium, a sodium, a chloride, and a CO2? That CO2 has nothing to do with the patient's lung. That has to do with the patient's metabolic status. So venous CO2 is an indirect measurement of bicarb. So as I'm losing potassium, I also lose H ions in my urine, and I become metabolically alkalotic with excess diuretic use. Everybody got that? I become metabolically alkalotic with excess diuretic use. You got to pay attention to the venous CO2 levels. Got to. That tells me that I'm giving too much diuretic. That tells me I'm giving too much. Everybody got that? So if you've been writing for the last 3 semesters that venous CO2 has to do with lungs, you are 100% wrong. Venous CO2, I work for renal guys, so you can see I'm passionate about this. Venous CO2 is a metabolic indicator of the bicarb level. So if the venous CO2 is high, that means my bicarb level is high. And because I'm giving diuretics, I'm peeing out potassium and I'm peeing out H ions. I have made the patient alkalotic. Okay. All right. Potassium sparing diuretics. Nice drug. Probably see the potassium sparing more so with my heart failure patients. Aldactone is a big common drug with heart failure. So if I'm hypertensive and heart failure, you might see them on aldactone, and your liver failure patients will be on the aldactone as well. So this means I don't drop my potassium with these types of drugs. So what's the potential?
Hyperkalemia.
You got it. That's exactly right. So now you're like, okay, well, I'll give one that drops it, one that can make it go high. So again, you as the nurse needs to pay attention to what their potassium levels are, and BUN, creatinine, GFR, all those things. Okay. I do see aldactone, a spironolactone, very commonly used with heart failure patients who are also hypertensive, and liver failure patients who have ascites. Okay. All right, so blocks the reabsorption of water and usually induced by aldosterone. So we're gonna block that action and we're gonna get rid of that excess water and sodium. We're gonna get rid of that excess water and sodium because aldosterone holds on to water and holds on to sodium. Oop. All right. Oh, that's like kind of a repeat. So there you go. It's repeat. So what happens? So what adverse effects? There's your nausea, vomiting, diarrhea. Every damn drug does. The issue here versus the loop is now we have high potassium. Do you guys see that? So again, anybody on a diuretic, you should be watching the potassium level. I don't care which diuretic it is, you should be watching the potassium level. You should anticipate with potassium sparing that it potentially could go up. You should anticipate with a loop that it'll go down. Okay. And dizziness, again, probably due to volume status. All right, thiazide. And this hydrochlorothiazide, you might see it abbreviated in a chart, HCTZ, HCTZ. So, and there's combination drugs with thiazide diuretics as well. The diurol or the hydrodiurol, I've seen them give IV. But a lot of patients are on HCTZ orally, this is Cedrix orally. I've also seen metolazone or Xeroxilin, which is a common one. I haven't seen the other ones given that much. And again, it could be because of whatever drug rep we have at the hospital. But the most common ones that I see are metolazone and the hydrochlorothiazide. So it inhibits reabsorption of sodium chloride and potassium. This one works in the distal tubule, not in the loop of Henle. And we excrete water, sodium, and chloride. Potassium is excreted to a lesser extent. So you see why they choose that one first before the loops? And the loops are a little bit more potent than the thiazides. And it dilates the arterioles by relaxation. So
Mrs. Colmery, did you just say that this is why they choose this one before the loops? Okay.
Yes. Because then we're not chasing the potassium as much, and the loops are a little bit more potent. I don't see them as a first choice unless we have somebody who has significant heart failure and a lot of other, but your beginning hypertensive patient with no other symptoms, they're probably going to start with the thiazide. So there's that's your SVR again. Remember, the potassium's not as much. Again, pay attention to their BUN, creatinine, GFR. I can overshoot and make the patient volume depleted. Here's where things will change. Let's say I've been on thiazide for years and my kidney function is getting worse. And that creatinine clearance, that is your GFR. So if my creatinine clearance is 30 to 50, I'm not going to be on a thiazide. I'm going to be switched to a loop diuretic. So if the doctor notices that I've had a change in my kidney function, they're going to take me off the thiazide and put me on the loop. Okay. So thiazide should not be used. This is your GFR. This is your GFR if it's less than 30 to 50 mLs. And that's a bad GFR. Okay. Like that's stage 3, almost to 4 kidney failure or kidney disease. All right. Side effects again, there's your nausea, vomiting, diarrhea. Leukopenia for this one as well. Dizziness again, that has to do with volume. That has to probably do with volume. Potassium, but not as significant as a loop diuretic. Your blood sugar can go up. You can have a high uric acid level. And then that hypochloremic alkalosis. So chloride, if I lose chloride in my urine, because remember the slide before it said the chloride gets lost. If I lose chloride in my urine, chloride is an anion, negative. It's a negative ion. It's a negative ion. So if I lose, I become more alkalotic. Okay. And it's really due to my chloride level dropping. So you want to pay attention on your BUN or BMP. You're looking at the chloride levels as well for the patient. Okay. So diuretics in general, thorough history, physical exam. If I have tenting skin turgor, sunken eyes, very dry skin, a lower blood pressure, you really need to have a conversation with the provider and say, I don't know, he might be getting too much diuretic. Pay attention to their physical exam. Look for those things that reflect fluid excess and fluid volume deficit. Because you can tip either way. You want a baseline fluid volume status. Anybody on a diuretic, you guys, you really should be measuring their output. Nothing drives me more crazy when I go in and we put somebody on a diuretic and I don't know how much urine they've made. That tells me how well the medication's working. So the minute they start them on a diuretic, you should put a hat in the room and tell them I need to measure everything that you're putting out. You want to know how well they respond to that diuretic. You're going to monitor this fluid electrolyte values, daily weights. I had a patient at one time that was 100 pounds of excess fluid only. She came in and was 100 pounds up in fluid. So you really want to pay attention to, any changes in the patient's weight. You shouldn't have significant weight loss or weight gain while they're in the hospital. If they're fluid volume excess, we should see them lose weight, yes, but they shouldn't drop 50 pounds overnight. Okay. You definitely want to get orthostatic vital signs. That tells me, too much medication or maybe too much volume's taken off. So pay attention to those orthostatic vital signs. Not only the blood pressure, you guys, but the heart rate. They might be lying and their heart rate might be 60 and then they stand up and their heart rate's 100. That is a significant change. So please pay attention to both not only the blood pressure, but the heart rate as well. Instruct patients to take the medications in the morning, especially with a diuretic, because nobody wants to get up at 2 a.m. and have to pee. So, when we give them twice a day, we give them at like 8 a.m. and 4 p.m. Because remember, LACE-6, hopefully by 10 p.m. they can go to bed and they can stop peeing, for the night. So really educate your patient so it doesn't interrupt with their sleep. And then again, you're going to monitor their potassium levels. Absolutely. If I don't have any kidney dysfunction and I am lacking in potassium, I could educate the patient on increasing the amount of potassium in the diet. So everybody wants to pick bananas. I'm going to tell you that won't be the answer on boards. Some of these other ones might show up, I would think. Everybody knows bananas. Cantaloupe I didn't put on there, but cantaloupe actually is a good choice as well for potassium. So you may have to tell them to eat more, except if they're on the potassium sparing drugs, because remember that can make their blood pressure go up. Hence why you need to know what type of diuretic. You can't just say a diuretic. Digitalis, and I think I'm the first one to teach you about Digitalis or Lanoxin. Digitalis is a great drug for atrial fibrillation and for heart failure patients because it helps with contractility. So I'll talk about Digitalis in a future presentation. But if my potassium level is low, and I am on Digitalis, it could make the patient become digtoxic. So anytime a patient who's taking diuretics with Digitalis, you must monitor the potassium level. And if the potassium level's low, you need to treat the potassium before you give the Digitalis. Digitalis is a big, big drug. Digoxin is another name. But if my potassium level's low, it can increase the potential for the patient to become more toxic. Patients with diabetes who are on thiazide should monitor their glucose levels and watch for high levels. Remember, that was a side effect. So telling our diabetic this could affect your blood sugar, they need to maybe monitor the blood sugar a little bit more frequently. Teaching the patients to move slowly, most important, because that's the patient that's going to come in that cracked their head on their end table or fell down the steps at home because they got dizzy. So sitting at the edge of the bed for 2 minutes and slowly rising so that they don't pass out or have some dizziness or orthostatic hypotension from getting up. Particularly with heart failure patients, if they have a excess fluid volume, in addition to being hypertensive, they should weigh themselves daily. Patients are taught to call their provider if they are up in 2 pounds within a day. That is a significant change. We don't wait, well, some do, till they're 20 pounds up and then they come in. So it's really important that we teach our patient to weigh themselves on a daily basis to see those subtle changes. Can we fluctuate by a pound or two? Yes. But if they're up 2 pounds, they need to have a conversation with the provider because he may give another dose of diuretic. Really, really important that you educate them on weighing themselves daily. And then make sure that they follow up. This is a big, big problem here too. I want to just pause on this one here. Some patients are really good about taking their medications and continue to take them even though they've been vomiting and having terrible diarrhea. And now they've really made themselves volume depleted. And they come in and they're in hypovolemic shock. So when patients start throwing up or having excessive diarrhea, they need to call because he's probably going to adjust the dose because they're losing volume. Okay, so again, back to educating our patients about how it is to give this medication or take this medication safely. Signs and symptoms of hypokalemia: muscle weakness, an irregular pulse rate, and feeling lethargy. So teaching the patient how to take their pulse, crucial. Teaching the patient how to take their pulse. And if they can't figure it out, maybe get a pulse ox and it'll take their pulse that way. And being able to feel if it's irregular or not. Okay, so again, a lot of education. If they have rapid heart rates or syncope, definitely we've given too much, they're taking too much diuretic or they've had excessive fluid loss. Maybe they were working outside in the garden, sweated all day, plus took their diuretic, and now they become volume depleted. So again, educating your patient, saying, hey, listen, take your heart rate, make sure that it hasn't increased or you don't feel syncope, they pass out. So do they feel lightheaded or dizzy? And then I don't know anybody who likes licorice as much as this, but I guess an excessive consumption can lead to hypokalemia in patients who take thiazides. My mother-in-law does like black licorice, but I don't know if it's excessive. I don't know exactly what excessive consumption means. But maybe you need to have that conversation with that patient who's on thiazides. All right, so adverse effects. I just told you this, so highlight this, circle this, star this. I always tell my students you can never graduate from Mercy College without knowing what a venous CO2 level is. So the patient becomes metabolically alkalotic because they're losing potassium and they're losing H ions in their urine. So they're becoming more alkalotic. Okay, so your venous CO2 level will be increased because remember the venous CO2 level is an indirect measurement of bicarb. I don't have blood gases, but I certainly have that venous CO2 to tell me what's going on with the patient. We're going to look for hypokalemia, tachycardia, hypotension, all of those wonderful things. And then hyperkalemia and potassium sparing diuretics. And low or high potassium can be very serious. With a higher potassium, the heart rate slows down and it can eventually stop if it's high enough. And where with a lower potassium, the heart rate gets tachycardic. So paying attention to that, really having a good idea of what's going on with patients' potassium is crucial on these patients. Safe administration of medication. All right, we're going to move on to calcium channel blockers. And this is what my mother was started on. She didn't have angina or angina, whatever you want to call it, but she was hypertensive. And I'm not certain why he went right to the calcium channel blocker instead of a diuretic. She never did have excess fluid. She just had high blood pressure. So maybe that's why. Very important that if you look, it blocks or slows impulses through the calcium channels and it decreases your heart rate and your blood pressure. So your brain already says, I probably shouldn't give a calcium channel blocker unless I check someone's heart rate and blood pressure. And I really don't care that somebody got it at 7 o'clock in the morning and you're going in at 10 o'clock to give a med, because a lot can happen between 7 and 10 o'clock in the morning. So you want to get that pressure right before administering that med, and you want that pressure. You don't want to give a medication and treat something that you haven't assessed. So again, any of these medications, you should get a set of vitals before giving them, even the diuretics. All right, so calcium channel blockers. Norvasc is like, it seems to be like the first choice. I used to see a lot of Procardia years ago. I don't see it as much. And if we need to give something IV, you're going to see a Cardizem drip. If we need to give a continuous drip, you're going to see Cardizem. And Cardizem is a great drug for somebody who's in AFib, who's got a high blood pressure, okay? Here's the problem. I've started Cardizem drips, heart rate's 150, blood pressure's, whatever. And I walk out of the room and come back in and their heart rate's down to 50. So you really, really, really need to pay very close attention when you have somebody on a Cardizem drip. Pay close attention to what their blood pressure and their pulse is doing, okay? Very, very important. The other thing with calcium channel blockers, and I had one student last semester who actually liked grapefruit juice, it can make the drug more potent and drop the pressure even more. So we teach our patients not to take the medication with grapefruit juice. Personally, I think grapefruit juice is gross, but there are people who like it. So that is a key thing that I will guarantee boards will ask you about. I don't know why. I don't know how many people drink grapefruit juice, but evidently they do. All right. And I never knew, I stole this from one of my books, but this very nice drugs. So VND, verapamil, nifedipine, that's Procardia, and D, that's Cardizem, diltiazem, that's Cardizem. So very nice drugs. If you can't remember what a calcium channel blocker is, that's a good way to remember it. What does it do? It blocks calcium, and we need calcium for contraction. So if somebody's in AFib and their heart's going crazy like this, we want to slow down that contractility and slow down that heart rate and bring down that blood pressure. So the side effects, as you can see, bradycardia. Now, I know you probably haven't learned about AV block. That's atrioventricular block. So that's a block between the atria and the ventricles. I think next semester you learn that. But it can block you down to where their heart rate's in the 30s. So it can slow that heart rate down. Pay close attention to their blood pressure. Pay close attention to their heart rate. And nausea, vomiting, diarrhea, yes. Peripheral.
I'm sorry, what did you say the very nice drugs were again?
They're right up there. So in the little pill bottles, verapamil, they're labeled on the they're labeled on the pill bottles. I couldn't think of the word. Verapamil, nifedipine, and diltiazem. So
Thank you.
VND, those are just the generic names of a calcium channel blocker. Okay, so that I don't know, it's a mnemonic for you to remember it, I guess. But please, please, please pay attention to the blood pressure and the heart rate. Do not give these meds if you don't know what their blood pressure and heart rate is at that exact time that you're giving it. And I watched somebody do this, went in, didn't take a blood pressure, gave it to the lady, and she died an hour later. Her pressure was in the toilet to begin with. I mean, she was going to die anyways. There is no reason to give a medication if you don't know what their blood pressure is. That's unsafe practice. Okay, Prills. Now, honest to God, I do not know all these names. I've given Captopril and I've given Lisinopril. But I know that an ACE inhibitor, because drug companies want to help nurses out, I know that an ACE inhibitor ends in Pril. So when I get a drug and they go enalapril, Captopril, I'm like, oh, that's an ACE inhibitor. And it's often the first line drug I told you for heart failure and hypertension. I can give an ACE inhibitor with a thiazide diuretic or a calcium channel blocker. Again, not for you to decide, that's the provider. It's for you to give the drug safely, okay? So we're gonna remember, we're not having that child. Your daughter's not going away to college, not meeting that husband, not having angiotensin II. So we're inhibiting that angiotensin converting enzyme. So it decreases the blood pressure because it doesn't cause that potent vasoconstriction. Okay. Why it works so well in heart failure, it also helps with the preload, and that's down here, third one down, third bullet down. And that's why it's such a great drug, because it does two things. It helps with preload, decreases the amount of volume that gets dumped back into the heart, and it helps with afterload. So it helps on both sides of the heart. So the heart doesn't get excess volume in it and goes, oh my God, I don't know what to do with this volume. And then, oh my God, I can't get it out. So it helps with the preload and the afterload. Hence why ACE inhibitors are a gold standard for heart failure, because in heart failure patients, they have too much volume and there's too much resistance coming out of their heart. So that's why this drug is so beautiful for heart failure. It helps the patient diurese, therefore decreasing the blood volume, decreasing the amount of volume that goes back to the heart. And there's your afterload right there. So it's used to prevent complications after MI. A lot of patients after they have a heart attack will be put on an ACE inhibitor. Ventricular remodeling is not good. That's when the left ventricle starts hypertrophy and it's sort of restructuring itself. That's not a good thing. So it helps with that. And it's shown to decrease morbidity and mortality in heart failure patients. It is the drug of choice of hypertensive patients with heart failure. Drug of choice, because it does both. Early on, so back to our diabetic patients or early hypertensive patients. Early on, the ACE inhibitor is sort of renal protective. It's sort of a good drug in the beginning, okay? And it inhibits, it reduces that amount of protein that we dump in our urine. So that's a good thing, okay? Standard therapy for diabetic patients to prevent those changes in the kidneys of that diabetic nephropathy. So it's a great drug early on. When the kidneys start to fail, it's sort of not a great drug because it can cause hyperkalemia. So anybody that is on an ACE inhibitor, you should be monitoring their potassium levels. So my dad, I'll use him as an example, bad diabetic, started on the ACE inhibitor, never had hypertension, was started on the ACE inhibitor, sort of protect his kidneys from this diabetes. And he called me and he said, my potassium's 5.9 and they're making me take K-oxalate. And I went, what? You know, and at this point, we didn't know that he had kidney disease yet. This was earlier on. And I said, list your meds for me. And he was on lisinopril. So they stopped his ACE inhibitor because it caused his potassium level to go up. So anybody on an ACE inhibitor, you should pay attention to their potassium levels and their kidney function. So I want you to write next that BUN, creatinine, and GFR. Now, the big problem that patients are usually not compliant is this dry, non-productive cough. It does stop. It does stop if you stop the med. You know, if patients say, I can't take this cough, it's so annoying, put me on something else. Once we stop the ACE inhibitor, that cough will go away. Angioedema, and I am telling you, I have seen it where the face is totally swollen. Somebody actually had to get a trach because of the ACE inhibitor. Big, big, big problem with ACE inhibitors is that angioedema. So really pay attention. Patient says, oh, it's hard to kind of swallow and my tongue feels kind of swollen. Pay attention to that because they could be having some angioedema. So you want to make sure that you get that taken care of right away. So what does the ACE inhibitors do? They decrease that peripheral vascular resistance without increasing the cardiac output, cardiac rate, or contractility. So it's going to just help with that vasodilatation, hence why your side effects, if you know what it does, then you know that the side effect could be that I could drop my blood pressure, okay? And I could be dizzy. There's your GI distress again. And then the cough. I want you to understand, you got to educate your patient because they will want to stop taking this because it's a dry, non-productive cough that drives them nuts. Okay, not everybody gets it, but it is a common side effect. ACE inhibitors can cause renal impairment. So remember what I said, great early on, renal protective early on, but can definitely transition. And that's one of the first things that my renal doctors stop is the ACE inhibitor when somebody comes in with a dysfunction in their kidneys. So when they come in with a decreased GFR, an increased BUN, increased creatinine, first drug they stop, ACE inhibitors. So very, very important that you pay attention to the kidney function when they're on an ACE inhibitor. And I already said that you need to pay attention to the potassium levels. Now the ARBs, so these were like newer kids on the block, and the ARBs work a little bit different than the ACE inhibitor. So it's a different, it binds with the receptors. So it's not the converting enzyme in the lungs. It occurs elsewhere. The beauty of this is that these patients don't have the cough. So it doesn't block angiotensin converting enzyme. It will actually bind with the receptors and doesn't allow for that angiotensin to occur. So the patients will not complain of that cough with the ARB. So, and I said, my friend who was on an ARB said I didn't like the ARB. She said she'll deal with the cough with the ACE inhibitor. Most patients find that the ARBs are a little bit more tolerable. Monitor first dose syncope. And I want to just tell you that's on any drug. How do I know how you're going to react to a calcium channel blocker? I don't. So you give that drug and it's their very first dose. You as a smart nurse go back in and reevaluate their blood pressure hour after they've taken it. Check their blood pressure and pulse prior to and after. And after. Don't you want to see the response? You know, if their pressure was 160 over 100, you as a nurse should go back in and say, well, I better make sure that's down to at least 140 over 80. Go back and evaluate, was that drug effective? Okay. Bradycardia is common and it's a good agent in patients with hyperkalemia. So the nice thing with these drugs, they all end in sartan. And again, I don't know all these. I've given candesartan and losartan seems to be the big one that we're using at Mercy, but they end in sartan. So if you see the word sartan, you know it's an ARB. And you know that it doesn't have the dry cough common with the ACE inhibitors. Okay, so when you're talking to the patient, you go in and say, oh, I see you were on an ACE inhibitor, they're switching you to an ARB. Let me just tell you that you won't have that dry cough like you would with the ACE inhibitor. So there's your education for the patient. Hyperkalemia less likely to occur than with the ACE inhibitors. Common side effects, nausea, vomiting, diarrhea, chest pain. I've not had patients report that to me. Any drug can cause fatigue. That's another common thing. The anemia, I haven't seen that as well, but I guess, you know, it's here, it's in your book. I guess it's possible, but I haven't seen it. And then urinary tract infection, which is kind of interesting. Because that's what my colleague got admitted with was a UTI and renal failure. And she was on an ARB and switched over to an ACE. So that's kind of interesting. I don't know if they're connected or not, but perhaps it is. Comparison of ACEs versus angio, they're pretty equally effective. Both are well tolerated. The ARBs don't cause cough. I told you my friend wanted the ACE instead of the ARB. Again, it's patient specific. It's not clear if the ARBs are as effective as ACEs in treating heart failure or in protecting the kidneys in diabetes early on. So that's the difference. That's the difference. Like my dad, when we put him on the ACE early on, they didn't put him on an ARB. They put him on an ACE. Same thing with heart failure. We don't know if it's as effective. So I see more patients in heart failure on the ACE inhibitor instead of the ARB. All right, so we talked a little bit about this in the potassium sparing diuretics with the aldactone. Very common. So the aldosterone increases sodium reabsorption. Therefore, then we hold on to water and then we become hypertensive. So we're going to give the aldactone to block the hypertensive effects of the aldosterone. The big side effect, though, with these, you guys, is that the potassium could go up, okay? Right there, hyperkalemia. And then again, if I'm on aldactone and an ACE, I'm definitely increasing my risk for a high potassium level. So pay attention to what that patient is on. Have I had people on ACEs and aldactone? Yes. So please pay attention to their BUN, creatinine, GFR, and all their electrolytes. Adrenergics. So there are central, peripheral, and then there's combo. So we're going to talk about them individually. The alpha 2, and probably I'm going to guess you guys have saw the Catapress patch. And the Catapress patch, they put on their chest or their arm or whatever, it's not typically first line. This is somebody who's been through like all of the antihypertensives, and it really is sort of like not last ditch, but it's not a first line drug. The Catapress patches can be on for 7 days, and they're pretty significant. You know, this is a pretty strong drug. So this is somebody who's maybe resistant, and you can see adjunct drugs after others have failed. So they've tried the ARB, they tried the calcium channel blocker, that's not working. We're on to Catapress. So if you see a patient that's on Catapress, suspect that they're a pretty resistant hypertensive patient. You want to make sure that you don't stop abruptly, because you can have rebound hypertension. So if we decide, oh, I don't feel like taking this anymore, their blood pressure can shoot way up. That's rebound hypertension. So pay attention to that as well. And again, education with them regarding their medications is so important, that these are lifelong. You know, your blood pressure, your hypertension is not going away. Your hypertension is just not going away. So it's going to be lifelong treatment. One of the other side effects, excuse me, of Catapress is sedation. So, you know, if I'm working, I mean, it's probably not a good drug of choice, because it's going to make me sleepy. So pay attention to that as well. They might become a little bit more sleepy because of this medication. Again, I don't see this as a first line treatment ever. When I see patients on this, they're on about 5 other things, and they're just resistant to all the other meds. Okay, so Cardura is probably the one I see most commonly. The alpha 1 dilates the arterioles and venials. So arterial is on the artery side, and venial is on the vein side. So we're going to reduce peripheral vascular resistance. Syncope, you might have patients who are orthostatic. They might be tachycardic, so pay attention to that. Not a first line drug again. Postural hypertension is a big problem. First dose syncope common. Watch 30 to 90 minutes after dosing, because they can drop their blood pressure. So they recommend that this particular medication, give at bedtime, because I'm laying in bed, so I won't fall over. So very, very important that first dose syncope is common. So you give them that Cardura, you go back in 30 to 90 minutes and take that pressure again and see how your patient's doing. Dual action alpha and beta receptor blockers. So Coreg, and I'm sure you've seen Carvedilol. I'm sure of it, because like my heart failure patients are on that. Very commonly used. Labetalol, I see a lot in the ICU. I can give IV for people who have blood pressures greater than like 160. So I've seen labetalol more often than not given in the ICU. IV push, somebody who's nothing by mouth. We'll start on Coreg, you know, if they're pretty stable, used in hypertension, and definitely used in heart failure. Great drug. Of course, we need to pay attention to a couple things. So because there's some beta blocking in there, people who have bronchoconstriction, such as an asthmatic or COPD patient, we are very concerned about giving these medications because it can exacerbate an asthma attack. So beta blockers, now don't come to me and say, my patient last week was asthmatic and they're on a beta blocker. Sometimes they do okay, but we really do worry about So you're going to pay attention to their lung sounds. You're going to pay attention to their breathing. If they have issues with COPD or asthma, we do have to worry about that blocking that beta 2 and causing or bronchoconstriction. Okay. Beta blockers. So when I think of beta blockers, and more often than not, we hope it's cardioselective, so it's only going to work for the heart, versus non-cardioselective, it could sort of just affect everything, blood pressure, heart rate, and the bronchial tree. That's where we get into problems with that bronchoconstriction, okay? Because we don't want them to have some bronchoconstriction because it's going to exacerbate their lungs and cause an asthma attack or an exacerbation of the COPD. So we're very, very careful in patients. So particularly we would want a cardioselective beta blocker versus a non-cardioselective, okay? Better choice, cardioselective versus a non-cardioselective, better choice for somebody with lung disease. Absolutely blood pressure and pulse. And I'm sure you probably saw in their MAR, please hold beta blocker if heart rate less than 60 and blood pressure less than systolic of 90 or 100. And every physician's different. Honest to God, do not ever give a beta blocker unless you know what their heart rate and blood pressure is right then and there. Because no one will stand up in court and they say, well, their heart rate went down to 20. Well, what was it before? I didn't take it. That is negligent. So you will absolutely take a blood pressure and pulse prior to admission. So beta blockers end in OLOL. The one that's non-cardioselective, this Inderal, that propanolol, we use for liver disease. It helps with portal hypertension. So somebody with end-stage liver disease who's got a lot of pressure in the portal vein will give Inderal. Probably the most common beta blocker that you see right now is metoprolol. Very, very common. Patients are to be put on a beta blocker after they've had an MI. Unless there's some contraindication. So it's a drug of choice, somebody with ischemic heart disease. So somebody who lacks blood flow to the heart, because we want to dilate those arteries in the heart and get blood flow to the heart. Big problem with this and where the compliance comes in is the sexual dysfunction. A lot of men will stop taking it. They don't like the way it makes them feel. It really flattens out their mood. Not just men, women too, flattens out their mood, can cause some depression. It can really, sometimes they'll use beta blockers for anxiety. So you can see how that can kind of bring people down. So they'll stop taking it because they don't like the way it makes them feel. If I am diabetic, we want to make sure that they monitor their blood sugar because it may mask the symptoms of hypoglycemia. You know, normally we get a little anxious, a little angry, a little sweaty. It could block all of those symptoms. So the patient won't know that they're hypoglycemic. So we need to teach the diabetics to make sure that they're monitoring their blood sugar. Never stop abruptly, it can cause chest pain. And then if I am on a beta blocker, you may not see an increase in their heart rate with activity. You know how we normally, when we exercise, we see that increase in our heart rate. Because it's blocking that, you may not see an increase in the heart rate with activity. But all the beta blockers end in OL. Excuse me. Okay, so another cute little picture. And what it does, it decreases the heart rate, decreases the force of the contraction, and decreases the conduction between the atria and the ventricle. So it slows things down. Hence why we need to make sure that we have an appropriate heart rate when we give a beta blocker. So if it's less than 60, you're making a phone call, you guys. You are making a phone call. Can these beta blockers cause heart failure? Yes. So that's where you look for the fluid volume excess. Do they have crackles in their lungs? Do they say they're up 20 pounds? Pay attention to your patient's physical exam when they're on the beta blockers. Great drugs can cause lots of side effects. So make sure that you're really assessing your patient very thoroughly to make sure that they're not having any complications to taking those drugs. Okay, vasodilators. So with vasodilators, and I think I'll talk about the last three, well, actually the last two, the Clorapam and the NitroPress. I want you to put next to that IV drip. So it's a continuous IV drip. Those are probably more often than not seen in the ICU. So we'll talk about that in a minute. Hydralazine, a beautiful drug to decrease afterload, or that's SVR, on the arterial side. You can give that orally or you can give it IV. And I'm sure you probably have seen it as a PRN order on patients, 10 milligrams every whatever for systolic greater than 170. Nice drug to help with afterload reduction.
Did you say IV or oral?
For hydralazine, yes.
Okay.
Yep, you could take it by pills. But you know, more often than not in the ICU, if they're nothing by mouth, I'm giving it IV to bring down that pressure, especially if somebody's pressure's, you know, 180, 190, we're going to give it IV. We're not going to wait. But when I go home, I could be on hydralazine 3 times a day and be fine. The Clorapam and the NitroPress, really with those people who have those blood pressures that are 200, 300, seriously acutely ill patients that need to be in the ICU. That's a continuous drip. And we are adjusting and titrating that drip to get that blood pressure down. So these act on the arterial side, dilate, decreases the SVR, decreases afterload. Okay.
Dr. Comer, is SVR like the same as afterload, right?
Yes.
Okay.
Yes. And that's a very good question. So afterload is a concept. Afterload is the pressure, or the amount of pressure the heart has to work at to get out of the body. SVR is how we measure it. So they're essentially the same. Make sense? So next semester, I'm going to teach you how we measure the SVR, but the afterload and preload are concepts. Preload is about volume. Afterload is about resistance. The SVR is how we measure that resistance. Did that help you, Lisa? Good. Okay, great. Okay. All right. So if we dilate and decrease that afterload, dizziness and change in the position, see how the common theme here that we're going through with these meds, very common theme. You need to take with meals. We tell the patients to avoid taking hot baths and put spas there. I don't know who has time to go on a spa, but it could make the blood pressure drop even more. So we really don't recommend these patients hanging out in a hot tub for, 2 hours. Okay, so very important because it can vasodilate them more and they can drop their blood pressure. Nasal congestion and tearing are common. That's a side effect that'll drive them nuts. And they can have constipation and peripheral edema. So here is the hydralazine that I talked about, guys. So orally and injectable. And again, like I said, in those hypertensive emergencies, orally is, hey, they figured out that I'm hypertensive, I'm going home on it, and they're going to adjust it orally. I'm going to give it IV when I got to get that blood pressure down right now. Okay. I've not, and they said lupus, I guess, with hydralazine. I've not had a patient say that they had a lupus-like reaction from it. Big things are they're going to drop their blood pressure, they're going to be dizzy, they're going to have a headache, nausea, vomiting, diarrhea, all that stuff. Okay. And I've not had a patient tell me about the B6 deficiency. Something new for me. This nitroprusside or NitroPress, or you might hear me say Nipride because that's the old name for it. And I apologize, I'm trying to use what's in your book. This is definitely in intensive care, definitely titrated. This is every 5-minute blood pressures, every 2-minute blood pressures. I'm manipulating this IV drip because I got to get this blood pressure down. This patient's going to have a stroke. Make sense? So I got to get this blood pressure down because they're going to have a stroke. The big thing with this drip, and believe it or not, if we've got it running at pretty high doses, it can cause cyanide toxicity. So we do a cyanide level. Yes, I just said cyanide. So we would do a cyanide level on this patient to make sure that we're not giving too much. Patient starts getting confused and all these other little things. You see these changes, we worry about them becoming toxic. So we can draw a level. That's the biggest thing that I worry about with nipride. I don't see it as much anymore. We're using some other drugs. We used to use this a lot more, probably maybe 10 years ago, but some physicians still like to use it. Decreased platelet aggregation, that means I'm going to bleed. So the platelets won't clump together, so I have an increased risk chance of bleeding. This direct renin inhibitors, this is somebody who produces too much renin. Remember I said we can get a renin level way back? I produce too much renin. I have not given this drug. I have not met a patient yet in the practice that I'm with that has excess renin. He draws levels all the time on them. So you might see this. I've not seen it as much, but here's look for high potassium level and drop in pressure. That's all I have to really, not too much on this one.
Dr. Colmar, I have a question, just kind of as you say we can draw levels on them. If we're seeing these symptoms and you think a level needs drawn, do you have to get a hold of the doctor, wait for that order, or if you're in a stat situation, do you just like draw it? And I mean, how do you go about that?
That's a good question. You remember my last, well, maybe you don't know, my last 13 years before I went into education was in the ICU. So I always had a resident to grab and put in my pocket. So I was lucky enough to call the resident on call and say, this person, blah, blah, blah. The smart nurse, if a physician orders nitroprusside, and he's there and he's talking to you, I want him on nitroprusside. You say, hey, can you write a PRN order for me to get a level if there's a change in mentation? That's how I'd cover myself.
All right, thank you.
You're welcome. Okay, we're almost done with this and then we can go home. No, we are home. Oh my God, I can't wait to say that in the fall. Okay, so before beginning therapy, you got to have a thorough health history, head to toe physical exam. Look for those contraindications, just like I said with those beta blockers. Are we concerned about bronchoconstriction, exacerbating their asthma, making the COPD worse? And then always, always, always go back and evaluate. How did they respond to me giving this med? Oh, I gave it at 10 o'clock. I should go back at 11 o'clock and see how they're doing. Always go back. All right, educate. We already talked, not to miss a dose. And then my mother-in-law, who's got memory issues, she said, hey, should I take 2? Because I forgot it yesterday. And I'm like, no, 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 no. So really keeping them, I gave her a pill box. I have a sign in her room, take your medications. She would still, but don't ever double up because now you're going to make them probably drop their pressure. One of the things is they do talk about journaling. My sister just saw a kidney doctor about a month ago, and he asked her to take her blood pressure for a month straight. And when she went back to see him, he wanted to see what her blood pressure was doing. So asking your patient to really keep an eye on it, keep a journal so we know, what time of day that blood pressure goes up, or what do they look like, what's going on in their life, or why that blood pressure went up. Not to stop their medication. So very important that you have that conversation. Hey, if you don't like the side effects, you need to call your provider and say, I'm having bad side effects, but please do not stop abruptly. You can have rebound hypertension and possibly lead to a stroke. Okay. Oral forms can be given with meals, so it's more gradual and effective. Some of the pills like Toprol XL, that's metoprolol, XL, extend release, you don't crush. So make sure you're paying attention to what oral forms it is. If somebody has issues swallowing pills and you go, oh, I'll crush it for you, you're going to bolus them with too much medication at once. It's supposed to be extend released. Get the medication changed. Somebody in the ICU when I was going to give meds crushed a 240 milligram Cardizem tablet that was extend release and gave it all at once. So the patient got 240 milligrams of Cardizem at once. instead of over 24 hours. So do you guys see that? So if it's extend release or something along those lines, you've got to get it switched. You cannot crush any of these that are extend release or sustain release. IV forms, you're going to probably be in the ICU and you never run these without a pump. Never. You're not going to go, oh, I'll adjust it by drip. You never run without a pump. Teach them to move position slowly. And I can't tell you how many people that came in with a subdural hematoma or bleeds because they got up too fast. So really educating your patients. Sit on the edge of the bed in the morning. Don't move. Sit there for a minute. If they start having unusual shortness of breath, difficulty breathing, swelling, suspect heart failure. Shortness of breath, difficulty breathing, swelling in the feet, weight gain, suspect heart failure. Remember what I said, they shouldn't gain more than 2 pounds overnight, right? So telling your patient, if they say, oh, my shoes are too tight, that means their feet are swelling up, you guys. Suspect heart failure. Male patients, I already talked about this. That's why they'll be non-compliant, because impotence can be a side effect and they won't take it anymore. So really maybe having that conversation with the provider of like maybe a different choice of meds instead of a beta blocker. Serious side effects. So if they're really passing out or having dizziness, they need to have a conversation. They shouldn't stop their med. They need to contact their provider and ask them to maybe reevaluate their medications. I already talked about hot tubs. I already talked about this in the beginning. Do not take anything over the counter. Like, and I can't think if she was from Law and Order, but she doesn't take the decongestants unless it doesn't affect the blood pressure. Have you seen that Coricidin? Nobody's seen it. Nobody's seen it. Okay. Well, anyways.
I've seen it.
Oh, thank you. Good. Okay. So because it can cause hypertension, some of those decongestants and those medications, those are over the counter. So it says really big, not safe for blood pressure. So really educating your patient, hey, you need to pay attention to what can affect your blood pressure. All right, let's finish this up. So hypertensive emergency, you've got to lower it to prevent damage to target organs. And those target organs are back in that picture that I showed you in the beginning. Eyes, brain, heart, kidneys, right? Go back to those end organ failure things. So we want to get it under control in hypertensive emergency. Hypertensive urgency, blood pressure high, but no evidence of immediate or target damage. So it's a play on words here. All I know is if their blood pressure is up, we need to get it down, right? What's important though, somebody who's used to a high blood pressure, dropping them down to 100/50 is not good. And my aunt, she went to her next door neighbor who was a doctor and he gave her blood pressure meds and she never checked it again. And she actually stroked because her pressure dropped too low and she didn't perfuse her brain. So when we have patients that have blood pressures that high, we don't go from 180 to 100 systolic. You will cause even more damage. So it's a slow reduction of the blood pressure. And it's right there. And no one's going to ask you what percent, but it's a slow reduction. And do you see I get down to 160/100 over 6 hours? You were like, oh my God, that seems like forever. You do not drop them down quickly. They will stroke. Okay. Slowly. Exceptions are extreme ischemic stroke or aortic dissection. The aortic dissection, the higher the pressure, the potential for me to have a ruptured aortic aneurysm. So we do want to get it down. Do you guys get that? Aortic dissection means that there's a part of that vessel that's damaged and it's ballooning out, and the higher the pressure, it's actually going to rupture and then the patient dies. So that we may take down very quickly. Do you guys get that? So really depends on the medical diagnosis. I already talked about, this is your nipride or your nitroprusside. This is your Corlapam. Nitroglycerin, I didn't spend a lot of time, and I'll actually talk about that when we get to coronary artery disease. Nitroglycerin is a great drug for arterial or venous, I apologize, venous dilation. So on the venous side, nitroglycerin does a great job decreasing preload to the heart. Nitroglycerin does a great job of decreasing the preload or volume back to the heart. It's a great drug for heart failure patients. This patient should be in the ICU, nowhere else. And they should be monitored. And when I mean frequent monitoring, they probably have an arterial line in, and we have a continuous readout of their blood pressure. Close monitoring, look for headache, nosebleed, all those fun things. We might give medications. Remember, urgency is not as serious as emergency. And I'm not going to ask you, please tell me the difference between urgency and emergency. That's stupid. But understand that you don't want to bring them down quickly on any patient, because you'll cause more problems than not, okay? You definitely are going to closely monitor them. Do you see the blood pressure every 5 to 15 minutes? Patient's going to have a headache. You might see them on a beta blocker. Labetalol is a good one to give IV push. Like I said, I've given it for a systolic greater than 160. And I can give clonidine as well. And then finally, teaching your patient how to monitor their blood pressure. So I bought my mother-in-law one from Amazon. One button, she pushes it, and I have an indication of what, because she can't do the other. And it's been really, really helpful for us to sort of kind of track her blood pressure. So that might be something that you can talk to your patient about. Definitely talking to them about not skipping their meds and all those other things that we talked about. Perhaps a home care nurse goes in and just makes sure that there's compliance with their medication as well. And then any healthcare resources that they might possibly need. Last step, patient verbalize understanding plan of care and drug therapy and necessary lifestyle changes. So I would say make that more specific if you were actually writing this as a plan of care. And reported adverse drug effects gave me 5, told me that dizziness, told me to, B6 deficiency, told me a rash, told me this. So patient reported what adverse drug effects they need to know and to report to their physician. And then patient consistently adheres to plan. Absolutely need to make sure that these patients are compliant with their medications, because all that this can do is just cause more problems. All right, that is it. Questions? Comments?
I have a question, quick question. Under when we just discussed the hypertensive emergency, how you were talking about the exceptions with the ischemic stroke and aortic. What did you mean by that? Like, do we have to decrease it quicker? Is that what you're saying, their blood pressure?
Yeah, Courtney. So with an aortic dissection, we look at the aorta coming off of the heart, it has, and you really should look at the pictures because it's crazy. The vessel has split apart and there's a weakened area. So if my pressure is really, really high, that's going to rupture and I will bleed to death. With ischemia, because I have lack of blood flow, I want to get that blood flow back to the brain as well. Okay. So we really want to get things under control with those two, because the ischemia could be worse if I have higher blood pressure in the brain. Okay. We want to get, yes, we may be a little bit more rapid, I guess is the question, the answer to your question, with bringing down that blood pressure, because that patient will die. John Ritter, who he was from Three's Company, died of aortic dissection because they died quite rapidly. You guys don't have a clue who John Ritter is, do you? No.
I know who John Ritter is.
I know.
I do.
Tripper.
Yeah.
Dr. Colmer, I have a question.
Yes.
You said urgency is worse than emergency, right?
Oh, emergency's worse.
Emergency's worse.
Yes, because when we're looking at emergency, if you look up here, there is, we want to prevent that end organ damage. We want to prevent that kidney damage, those kind of things. All I want to say about either one is I'm never going to ask you, please tell me which one's more serious. That's a knowledge question. Nobody cares. What I want you to think about is I'm taking care of somebody with this pressure that's high. Okay. And I don't want to bring it down so quickly that I cause even more problems. So you can see that when they have those high elevations in that blood pressure, we don't just go immediately down to 100 systolic because you're going to cause more problems. So I won't ask you the difference between the two.
Okay, thank you.
You're welcome. Any other questions?
Quick question on the test for the medications. Are you going to put the generic and the trade name?
Always. That's our, Kirsten, that's our testing rules or whatever. I just want to caution you guys. NCLEX only gives you the generic. But yes, Kirsten, I'm going to give you both.
Thank you.
Yep.
And Mrs. Comer, you would say mainly just with looking at all this material for the test, like kind of picking out the big things, the big differences.
This, boy, you guys are really kind of you're trying to pull the answers.
I only have a short period of time.
You know, well, I've been in nursing school a lot of times. But what I want you to think about, and if you get how I've said things, how do you give this drug safely?
Okay.
Smart nurse knows that if I'm going in to give a beta blocker, I need to make sure I evaluate the heart rate and the blood pressure, right?
Right.
Because I know you've read somewhere along the lines that you saw, a hold for them. If you don't have a hold for these meds, I call them and I say, when do you want me to hold this? And when are you safe for me to give this? Because some cardiologists are safe with me giving a ACE inhibitor with the systolic of 80. And I just do a Hail Mary when I give it, but he says, okay to give when their systolic is 80.
Okay.
All right, Jalea, what are you asking? Why is it when patients come in with a stroke? Yes. So Jalea is talking about why is it when patients come in with a stroke, they're okay with them having a high BP. And really, Jalea, they want it between about 140 and 160 systolically. That's where they want it. They don't want it too low, because remember my aunt, she stroked even more. They want it between 140 and 160 because they need to perfuse the brain because they're used to having such a high pressure. Okay. Okay, we're going to have we want the BP come down after strokes. So we're going to get it down, yes, but immediately after that stroke, they're going to keep them about 140 to 160. I don't know if you guys have seen orders from the neurology about that. I don't know if I answered your question, Jalea, or not.
Dr. Comer, I got one.
Yes.
So you said for the ARBs, you said bradycardia is common with that. But then it also says it's a good agent in patients with hyperkalemia. But with hyperkalemia, didn't you say that the heart rate was slow? That's like when you can die from like an increase.
Kinds of factors in there. It definitely can. Not everybody who takes an ARB is going to have hyperkalemia. Do you know what I mean? Not everybody. Remember that the hyperkalemia with the ARBs is not as significant as the ACE. Do you know what I'm saying? So the ACE inhibitor, a little bit more of a potential for a high potassium versus the ARBs. But again, it's assessing that patient and going, holy crap, I better let somebody know they're bradycardic. Do you know what I mean? I don't know if I answered that question.
No, you did, but I was like, I don't know. I'm like kind of confused because if they do have hyperkalemia,
who says
we're not going to give it then?
Who says they're going to have it?
I'm just if they did, because I don't know it enough to say that they will have it. I'm just saying if they do.
So boy, you're bringing a lot into that question. So let's just say, why am I taking the ARB? Why am I getting it?
Because our renin's high.
No, that would be,
no, like we want to check the renin, right? It blocks the renin. Yes, no, maybe.
No, that would be the direct renin. Yeah, that would be that fancy drug that I mean, we're going to get this. We're going to get this. We're okay. Oh, okay. Yes. Somebody asked a question and I can answer it if she wants to stay or not. But, so the choice is you don't have to decide, Lisa, which antihypertensive your provider is going to order. You as a nurse go, all right, I know with ACE inhibitors, I worry about the potassium level. I worry about their BUN and creatinine. So I'm going to look at those. That doesn't mean, like my girlfriend that's on ACE that I took care of this weekend, she's not hyperkalemic at all. That's just a potential side effect. Not everybody, is that helping? Okay, I see the light bulb going on. So not everybody has hyperkalemia. It's a potential. So again, that's that anticipating unexpected outcomes. You go, oh my God, I got to monitor. Oh, her case fine, good to go. Versus like a renal failure patient, then I'm going to pay attention to that because renal failure patients can't get rid of excess potassium. So I think you were putting too much into it. Just think about, here's a drug I'm going to give. And a lot of times you guys have a tendency to do that, is put too much, into the question. And if we're asking about an ACE inhibitor, unless we say in the stem, there are heart failure, renal failure, blah, 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 don't add that in there. My girlfriend's on an ACE inhibitor and she just has hypertension. She doesn't have renal failure, all those other things. So what do I need to look for with ACE inhibitors? High potassium, check their BUN and creatinine. Oh, she's okay. Let's keep going. Does that help clarify a little bit?
Okay, so I have a question now.
No,
if a patient, I can't. If a patient's on an ARB and say their potassium starts slowly going up, but it is helping with like their aldosterone, you know what I mean? And it is lowering, their blood pressure. So they want to keep them on that. Will they maybe put them on like KX later? Will they have like, maybe insulin and glucose like readily available, or like will they?
Ooh, girl, you're going to something crazy. Okay. So the smart nursing student or nurse who's taking care of somebody on an ARB, because that's what you're talking about, is an ARB.
Yeah.
And we get blood work every day. Everybody gets a BUN, a BMP, and a CBC. So you, as the smart nurse, goes up to the physician and said, hey, I've been watching this patient for 3 days and I see their potassium's going up. You don't want to wait until that issue of, oh my God, I need KX later, or I need insulin, or I need dextrose to give. You want to address it and say, hey, do you notice that their kidney function's decreasing and their potassium's kind of going up? It's your job as a nurse to notify them. What they do with that information, Elise, I always say, Pontius Pilate. Hey, doc, I gave you this information. I washed my hands of it. Now it's in your lap. So you call up and say, hey, I noticed that their K's going up a little bit. Kidney function's decreasing. They go, Elise, shut up, never mind, and hang up on you. You go, all right, doctor notified patient's lab values, blah, blah, blah. No orders given. You've now absolved yourself from responsibility. Does that help?
Yeah.
So you're definitely right that you should be really closely monitoring what their lab work is, because you are the person that's next to that patient and you are the eyes of that patient. So yeah, have I gotten yelled at, because I call on something? Yeah, I don't care. You get to a certain age that you just don't care. And I've gotten yelled at, you know what I mean? And I'm like, all right, whatever. And I wash my hands of it. But I've documented that I put it in his lap. He's the one that ordered the med. You know what I mean? So,
Yes.
So you as a nurse, yeah, you're monitoring it and you're saying, well, I'm going to notify him what he chooses to do with it after you've notified him. It's on him now, not you. You did the right thing. You notified him of that. Other questions?
Okay, I do have one more. I was kind of confused about SVR.
Mhm.
So you said that was like measures the amount of pressure that it takes for you to pump out.
It's the resistance that the heart has to work to get the blood out of the heart. So if my blood pressure is up and it's really, really constricted and I can't get the blood out, that heart has to work really hard, doesn't it? That's the afterload. We want that to be open so my blood goes out. We want it to flow freely. But if it's closed up like this, I can't get the blood out. I can't get it out. I'm constantly trying my hardest, hence why that ventricle gets large, because it's like you lifting weights and going, I need to get this out. I need to get this out.
Oh, and you said that's when it'll like cause the atria and the ventricle to like change shape, and that's bad.
The MI can, if somebody has a heart attack and that can cause the heart to change shape as well. what we were talking about on that EKG and hypertension. So if I have untreated hypertension for years, because I can, if I have untreated hypertension for years, that ventricle has worked against that resistance for so long that it definitely causes ventricular hypertrophy. It's made that ventricle muscle bigger.
Okay.
Because it's like lifting weights every day, and you make that muscle bigger. So it's a lot more, if that's why we want the resistance to go down so that the blood can get through and it can get out of the heart and the heart doesn't have to work so hard.
Since we're talking about the SVR, can you just one more time? Because I thought I had it and then I'm like, wait. The preload and the afterload, you said the preload.
Here's how I see preload and afterload. So preload is the amount of volume that is in the heart, essentially. So we should have the optimal amount, right? So that's where that cardiac output is. When I'm in heart failure, I have too much preload. I have too much volume. And let's take a balloon. We blow up a balloon, right? Ideally, nice size balloon, but if I blow it up too much, what happens?
It pops.
It can pop.
It could. Your atria and ventricles won't pop, but it could. So if you think about this, when the ventricle gets stretched because it has so much volume, and that's preload. Preload is reflective of volume. Preload is a concept. Preload is reflective of volume. When that heart has so much volume, that's why BNP gets released, because the ventricle is stretched beyond what it wants to be. The ventricle is stretched beyond what it wants to be. And the ventricle goes, I don't know what the hell's going on. I need to release this BNP to help me diurese. BNP gets released from the ventricles to help me naturally diurese without medication. Too much preload, too much of a balloon, I can't contract and work well, right? The heart can't work well. That's preload. Afterload is like that resistance that ventricle has to push against to get the blood out of the heart. And if it's really, really high, that blood pressure and that vessel's really, really tight, I can't get that blood out. It's too hard. It's too much resistance. We want to open that up. We want to open that up and dilate so that the heart doesn't have to work so hard to get the blood out. That's your afterload. The amount of resistance that the ventricle has to push against to get the blood out.
That's when, like, do you do like the vasodilator?
Yeah.
Okay.
Yeah. So the vasodilators help with afterload reducing. Increases your SVR because it opens those. So remember I said coffee stirrer really, really tight versus a straw versus a toilet paper roll. And those will come into play next semester when we talk about shock. But you want that vessel to be the perfect size. You don't want it too tight. The smaller the diameter of that vessel, the higher my blood pressure is. I'm vasoconstricted. The smaller that vessel is. So that's why you give the vasodilators and it opens up and oh my goodness, I can get the blood out. Make sense? Now on the other side, the preload, all that volume that comes back to the heart, all that volume comes back to the heart. I got a lot of volume on, right? I just drank a pot of coffee.
So that's where you want like the diuretics and
you
things.
got it.
Okay.
You got it. Diuretics help with that excess volume.
Yes. Okay. Thank you.
All right. Jalea, you had a question.
Yes.
What is it, love?
Okay. So 112 has been like a year ago.
Okay.
I don't remember
Okay.
the body water stuff.
Okay, so it's not so much about like what they taught you, the basics of body water. Let's just take this from the concept of a couple things. If I have a lot of constriction, high blood pressure, okay, what happens if I have a lot of pressure on the kidney? What happens to the kidney? Anybody?
They give out.
Okay, fair enough. It damages the kidney, not necessarily give out, but it damages the kidney. Okay. And if I cause damage to the kidney might think I need to release renin again, right? Because now the kidney's all messed up. It doesn't know what the hell's going on. Am I getting blood to the kidney? Am I not getting blood to the kidney? So the volume is increased because of the renin-angiotensin aldosterone. So if the kidney sense that there's a drop in the blood pressure, okay, the kidney senses a drop in the blood pressure, renin gets released. Renin then meets up with angiotensin 1. Angiotensin 1 travels to college into the lungs and converts that. And the kidneys, they're like, hey, I need blood perfusion, whatever, it will clamp down. Now, some patients, and Lisa was talking about this earlier, produce too much renin. Some patients produce too much renin. And what happens is this vicious cycle of the renin-angiotensin aldosterone system just keeps going. I just keep producing renin. No matter what's going on in my life, I just keep producing that. And the more that I produce renin, the more that I activate that angiotensin 1 to 2. Aldosterone, hold on to water. So we want to break that cycle. And I think Lisa was kind of going down that route with the renin inhibitors. If it's a hormonal issue, that's exactly what we would do, Lisa. You're absolutely right, is we've got to give that medication, stop that production of renin. Okay. So I don't know if I answered your question, Jalea, or not, or explain it to me a little bit more. So it's not about body water and shifting of sodium and all that fun stuff. Do you know what I mean? Like that you learned in 112. This is about, why do I have excess volume? Do I have excess volume because I'm in heart failure? Because my heart's failing, because I have blood pressure that's out of control. Okay. Do I have excess volume because of that? And I'm going to give a diuretic to unload that excess volume. Jalea?
Yes.
All right. Tell me if I did answer it or if I didn't answer it.
I don't know.
I'm not certain what you want to know about the body fluid portion. All that you need to think about when somebody is hypertensive, let's just say I go to the doctors and they say, oh, Lorraine, your blood pressure is 100 over, or 160 over 100, right? And we've gone 3 consecutive times. Is the issue that my blood pressure is up because I have too much volume on? And how would you know that? How would you know it?
Daily weights.
Swelling.
Checking for edema.
Okay. Not every hypertensive patient has excess volume. Okay. Let's go back to my mother, who's 100 pounds soaking wet, never had edema, was hypertensive. So we didn't put her on a diuretic. Do you guys see that? She didn't have excess volume. So again, using your physical exam, and again, it's not for you to decide which med they're going to start. It's for you to know how to give that med safely. Doesn't matter. Like when I went to work, I didn't say, oh, I know I'm giving thiazide diuretics today, or I know I'm doing this. I don't know that. When I show up and they say, Lorraine, you're starting the Bumax drip, I go, oh my God, I got to think about these things with the Bumax drip. I don't make that decision on what med they're giving. I have to give it safely. Did that answer it or not?
Yeah, I think.
I don't know, you guys. She doesn't sound very convincing.
I don't know. I think I'm trying to look more of the patho behind it all. I don't know.
So again, could I have kidney disease? Could I have bad kidneys and I'm holding on to volume and that's why I'm hypertensive now? Yes. Again, your physical exam is going to tell us whether this patient who's because you could be not fluid excess and be hypertensive, and you could be fluid excess and be hypertensive. Do you see that? So looking at your physical exam, do they have crackles? Do they have edema? Do they have shortness of breath? All of those things that tell me that this is a fluid issue. Then we're going to give diuretic.
Okay.
I'm not convinced.
Dr. Comer, real quick, with that sodium restriction, like to go with like the retaining water, the number was the 2,400. What number was that you said? I didn't
So,
get-
so your book says 2,400 and that's why I put it there. But more often than not, it depends on the patient and how severe the edema is. I've seen a 2 gram, so a little bit less than 2,400, and I've seen a 1 gram. I've seen people as low as 500 milligrams. So again, no one is ever going to ask you how much sodium should they be restricted on. That's up for the nephrologist to decide. You are the person that has to carry it out and educate them about it. So no one's going to say, you need to know, because some people are on 800s. Everybody is very different. You just need to know how to educate them about a sodium restriction and what that looks like and how to read the labels and say, you know, pickled beets are not a good choice because that'll bring your sodium level up. Does that help?
Okay. Yeah, I just wasn't sure if like it was like a set number. You know.
It varies. And, you know, like I said, I've seen one person just in my 30 years of 500 milligrams. I don't even know what you could eat with that low amount of sodium, but
water.
Maybe. Well, you got to watch the water too with the heart. So you're kind of screwed. So I'm like, okay, what are you going to eat? You know, air. I say you're going to eat air. But so it again, it's really up to the nephrologist to decide the amount of sodium. You just need to execute it. Do you guys see that? You're not going to be responsible to say, I think she needs a loop diuretic. It's for you to execute it. It's for you to give it safely. It's for you to say, hey, doc, she's got some ringing in her ears. Do you think you're giving too much Lasix?
Okay.
That help?
Yes, ma'am.
Anybody
you.
else? You guys have good questions. I had a nap today, so I'm ready to go.
Stop. Stop.
I have a question. I just thought of it. What was the biggest takeaway from the dual active beta blockers versus just the regular beta blockers?
So there's again, Kirsten, that's again a physician's preference. So there's not a big, oh my God, this needs to be a dual acting, or oh my God, this is cardioselective. Again, somebody orders Coreg, you go, I know what to look for. I know what to assess in my patient. I know how to give it safely. So there's not a, oh my God, you need to know the difference. It's for you to just give that drug safely. A lot of what you need to think about when you're thinking about boards and NCLEX and practice, it's about being a safe practitioner. So if you go in and give them a bunch of antihypertensives and you don't evaluate their blood pressure and you don't look at their heart rate, you're not really a safe practitioner. So again, you won't have to decide, Kirsten, whether it's going to be a dual acting or not. You just got to make sure you give it safely. Did that help?
Yes, but I was kind of like, just like knowing, like to give it safely, I was trying to think of the big difference takeaway as a nurse.
I don't
Or
think because you
not
would
thinking about that.
pressure and heart rate with both of those. Do you know what I mean? Because they've got beta blocker in them and they can drop the heart rate and the blood pressure with both of them. Do you know
Okay, so both pretty much just think that same thing, check
Yeah.
those first.
I mean, certainly any of these drugs, you should be taking their blood pressure. Now, some of them don't affect the heart rate. Beta blockers do. Calcium channel blockers do. So you got to know the difference.
Gotcha. Okay.
Anything else, you guys? All right, I'm going to stop recording.